I see from the list that JJ's here, Bonnie's here, Tom's here, Jeff, Bob, Bill can't make it today. Sue is going to be a little bit late. So I think all I have to do is check roll for Susan Miller and Reed. Either one of you are here? Okay, no. So we will proceed. And the first call of action is to call to order, which I do so. And if you have had a chance to look over
Robert,
the
I'm here.
meeting synopsis. Was that? Oh, Reed, hi, thanks. Great. If you can look over the meeting synopsis that was part of the board packet, I will entertain a motion to accept the synopsis as written whenever the time comes.
This Bill, I'll
Mr.
make a
JJ.
motion to approve.
Second.
Bill, you're here? Dang it.
Just jumped in.
Okay, and who seconded? Sorry about that.
JJ.
JJ seconded. All those in favor of accepting the meeting synopsis as written, say aye.
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 Any opposed, say nay. The ayes have it. What a great start to this meeting. All right, so I am going to move this over to Ali with the director's report.
Thank you, Robert. And we will have 2 new board members pending Senate confirmation next Tuesday, I believe, is the hearing. I just wanted to give the board an update on the consultant RFP and talk about next steps. Willis Towers Watson has partnered with OEBB since its inception over 14 years ago. And really much of the success that OEBB has experienced over that period of time can be really attributed to the contributions from Willis Towers Watson. The level of service to staff and leadership with the board has been unquestioned. And as was announced on January 21st for the board, after a very competitive procurement, Willis Towers Watson was not selected as the apparent successful proposer. Mercer was the ASP. And as for what that means in the near term, we have Willis Towers Watson under contract for the remainder of this year, and we'll continue working with them throughout the 22-23 renewal process. We will begin talking about what that transition looks like in the coming weeks once the procurement officially closes. I wanted to take this opportunity to really acknowledge and thank Jenny, Brad, and the rest of the team. It's really truly been an honor and a privilege to work with them, and we'll look forward to working with them, going forward through the rest of this year and make it a successful renewal. So we will be looking at other RFPs. We'll be looking at prioritizing that list, and we are legislatively mandated to conduct another consultant RFP in 3 years. So every 3 years, we are mandated to conduct a consultant RFP. So it's really business as usual for now, and details will be forthcoming probably by the next board meeting on the transition. And that's it, Robert.
Okay, any questions for Ali? Okay, next up on the agenda, COVID-19, you'd think I'd have that down by now. COVID-19 vaccine update from the carriers, and Kaiser is up first. Hey, Keith, I think you're muted. Keith, I think you're muted again.
That's 2 for 2. Am I okay now?
You are good, yes.
Okay, I will get right to this. As everyone's aware, overall Omicron-related activity is high, but appears to be peaking, and the projections are that it will continue to go down. However, hospitalization rates are high, actually as high as we have seen, similar to prior surge in the late fall, with over 150 Kaiser members hospitalized currently, which is twice as high as last year at this time. But the need for ICU care is lower. The daily case count is starting to decline as well. We are maintaining an active testing program. We're doing, our capacity is 3,000 PCR tests daily. We're keeping our turnaround time within 2 days. Just in January, more than 4,500 OEB members had a PCR test done through Kaiser Permanente. This is the highest monthly volume for OEB members that we've seen throughout the pandemic. The case positivity rate of people who are having testing done is 31%, which is also extremely high and higher than we've seen before. We're pleased that there's increased availability of home testing. Kaiser Permanente is reimbursing for home tests purchased at retail drugstores, and our members are able to order test kits, 2 per member per week, 8 per month online for pickup at one of our facilities. We plan to roll this out through our mail order delivery facility as well. We're continuing to vaccinate our members at a high rate. We have 16 vaccine centers going on. We're doing some innovative pilots, trying to open our facilities up on the weekends. Last weekend, we had 500 members vaccinated at Murray Hill with both COVID vaccines, flu vaccines, and we met other care gaps and care needs that they had. We're planning additional community partnerships to increase vaccination rates. Certainly we have concerns about delayed care for elective procedures as well as staffing. We're expecting those to normalize as the year goes on. Our ASC cases haven't been delayed due to COVID, but were delayed in the last couple of weeks due to staffing and ill calls. Those are all being rescheduled. Hospital elective cases, which had been elective due to surge considerations for things like weight loss surgery, hysterectomies, and joint replacements, are all currently being rescheduled, and hospital OR staffing is returning towards almost normal. Because of staffing challenges that every hospital and health system is facing, we have really well-developed plans for mitigating these, including offering premium pay and bonuses for our staff, hiring traveling staff and nurses if needed, using a National Guard and state supplemental staffing. We know this is going to be a long-term problem. We appreciate the state's efforts and funding for additional workforce development programs and plan to collaborate with other health systems for training needs. OEB, as I mentioned, just some specific data related to COVID activity. The rate of positive over the last month has been 31%. That means 3 in 10 people who had a COVID test for any reason at our facilities are positive. This is high. Very high rates of vaccinations. 91% of OEB employees have completed their vaccine series, and 65% of OEB employees have been boosted. Looking at OEB members, which is employees plus dependents, does go down a little bit to 81% have been completed the vaccination series, and 58% have been boosted. Currently, only 5 OEB members are hospitalized, and this is less than our average month over the last 2 years. Thank you very much. If there's any questions, happy to answer them. Great. I guess I'll turn this over to Yale for an update from Moda.
Okay. Thank you, Keith. Good afternoon. So currently in Oregon, 74.
We do have one hand up there.
Oh, sorry.
Sorry, Reed, I lost connection there for a minute, so I'm back. Reed, question, comment.
Yeah, Robert, I'm having, well, so I might have to log out and log back in. But Keith, did you say 5% of OEB members are hospitalized?
Oh, no, 5 members are 5 OEB members are currently hospitalized, and that's lower It's the low end of the average number of hospitalized for COVID over the last 2 years. It's mostly been sort of between 4 and 12 at any given month have been hospitalized. None are in the ICU. So I'm saying there's a high rate of COVID positivity, a high rate of COVID Omicron illness out there, but a low rate of number of OEBB members in the hospital currently in the Kaiser setting.
Okay, thank you. Jeff, question, comment?
So what are the ages or the age breakdown of those that are hospitalized?
I don't have that. I don't have that readily available, but we might be able to get that for you.
It's more curiosity, so that's all right.
Yeah. I mean, generally, it's always going to skew older in the hospital. Just that's the most vulnerable from Omicron and from COVID in general.
Well, I understand that Omicron is
Hi, Craig.
getting
How
the
are
lower ages than prior variants.
And the biggest factor is vaccination
Yeah.
status.
I understand. Completely understand. Oh, so
We've got a weird conversation going on somewhere.
It's been taken care of. So I think
Thank you.
I think we're ready for Moda.
Okay, thank you. So in Oregon, 74.8% of the total population is fully vaccinated, 82.3% have received at least one dose of any vaccine, and 41.1% have received a booster. Nationally, we're looking at close to 75 million total cases and 880,000 deaths. In Oregon, we have had 613,000 cases with 6,067 deaths. I'll now review the most recent data for our OEBB subscribers and know that our vaccine counts are derived from medical, pharmacy claims, and alert data as of 1/25/2022. So overall, 76.6% of all OEBB subscribers have had their full vaccinations, and close to 34% have had their booster. For a regional breakdown of those members fully vaccinated from highest to lowest, we see stability in our numbers. Portland Metro, 83.6% and 39.4% are boosted. In Eugene, 81%, 36.1% boosted. In Salem, 81.4% and 34.2% boosted. Oregon Coast is 76.6%, which is a nice jump. Central Oregon is 74.3%. Eastern Oregon is 71.6%. And Southern Oregon is 63.2%. Overall, 6,521 members have had a COVID diagnosis, and overall 42 members, up from 33, have been hospitalized with a COVID diagnosis. And overall, there have been 20 fatalities of our OEBB members. Thankfully, it does appear that the latest Omicron surge is showing signs of abatement nationally, as well as here in Oregon, as Keith mentioned. Hospitals are, however, still in crisis for the volume of patients, as well as the shortage of skilled workers. That remains a stark reality of what's going on out in the field. Lastly, I'll just discuss Moda's response to the new federal guidelines regarding rapid home testing. In full compliance, we began reimbursing COVID-19 at-home tests purchased by members starting January 15th, 2022, and after. Members can show their Moda Health ID at any in-network pharmacy counter when purchasing. Reimbursement options are available for members when they are purchased at one of our in-network pharmacies or an authorized retailer non-pharmacy location, either in person or in line. Reimbursement forms are available on our website. Purchased at a pharmacy or online pharmacy, and a different form is used when seeking reimbursement not at a pharmacy. Also, following federal regulations, we will reimburse members up to $12 per test for tests purchased on January 15th or later, and we will reimburse up to 8 tests per 30 days for each person on a Moda health plan, no matter if the tests are bought all at once or at separate times during the 30-day period. Moda will cover up to 8 tests if they are bought individually or in a pack that includes multiple tests. There are clear instructions on our website on how to find an in-network pharmacy, as well as more detailed instructions on this topic and an FAQ as well. We have devoted a website for OEB at www.modahealth.com/OEB/COVID. And that is my update from Moda.
Yeah, and thanks, y'all. There's one thing I would add to that as well. We also sent an email to all of the OEB entities, letting them know about finding the tests and the reimbursement form. And we also sent an email out to our OEB members that we had email addresses for with that same information.
Tom.
My question has to do with the differentiation between being fully vaccinated versus boosted. My understanding is that what it looks like is, particularly for protection against Omicron, there is the need to have 3 shots. And I don't know, and this is for both Keith and Yale, where do we go with this? Are we going to get to the point when we talk about appropriately vaccinated, we're going to be talking 3 shots versus the current definition of 2 shots, and then we give this addendum of percent boosted, which is, it's turned out to be almost half of what the quote fully vaccinated is.
Yeah, well, I mean, and Keith, you can feel free to chime in as well. I mean, I certainly would not argue that being fully vaccinated does mean getting both shots and a booster, and that would be the ultimate goal for the best protection you can hope for with Omicron. Luckily, Omicron, but there is no question that having both shots and the booster is going to give you the best protection and the best outcome in terms of symptomology of COVID if it's contracted.
Yeah, we'll just have to see whether that, I mean, there's a 5-month lag between the first 2 shots and then the 3rd shot, which is the booster. Agree that the more people who have 2 shots plus the booster, the better off everyone is going to be. I'm a little bit concerned that number's not going up, though I think we need to give a little bit more time to see what's happening.
Any other questions or comments regarding the vaccine updates? Thank you for that information, very helpful. We will move now. I think Jenny's up and Jesse to start discussing our preliminary medical and dental and vision renewal considerations. It's what we all signed up for. Let's go.
Thank you. Yeah, thank you. And thank you very much, Wwe, for the very kind words at the beginning. It certainly has been a real pleasure to work with OEB, and we're fortunate to have had the partnership. So thanks again. Yeah, so I'll be walking us through the renewals along with my colleague Jesse Knight. And I think most of you have met Jesse at this point. He's been assisting OEB for a few months now, both with the Center of Excellence project and coordinating all of the vendor renewal work. So Jesse will be talking quite a bit as well. Shoot, looks like some of our formatting got kind of messed up, but anyway, this is us driving into the future in another renewal year. So I guess we'll kick it off. So Rose, do you want to take us to the next slide? Well, the next one. Okay, so we've got a long afternoon for you, but we did break it up into 3 chunks. So today in this presentation, we'll be talking about the medical pharmacy renewals, the dental renewals, and the vision, and they are all on a preliminary basis. And then we've got 2 other presentations that we'll go over with you to go over the life and disability renewals and then the wellness program renewals. So let's go ahead and go to the next slide. Okay, so again, these are our renewal goals and objectives that we have talked about for the last couple of meetings, and are largely similar to the goals that the board has had in the last couple of years. So again, you know, I'll just read through them pretty quickly, but ensuring sustainable and appropriate rate positions for each one of the plans is definitely a top goal. We did say that we would review relativity or making sure that the rate is the correct rate for each individual plan design every 3 years. And we started doing that in the last meeting or two, and we'll definitely bring that back in the next meeting in March. Ensuring members have a meaningful choice or array of plans to choose from. And this year we did say that we wanted to take a look at member cost sharing, which we did last month. We've got an option included in the renewals for you today to take a look at what it looks like to make a reduction in some cost sharing on some of the plans. And then certainly we want to consider programs or plan design changes that will help to improve the efficiency of the overall program. And those include advancing coordinated care model efforts, advancing value-based reimbursement models, and the things that have been discussed through the innovation work group. Obviously, one of the goals and requirements is to meet our 3.4% cost growth cap, and so we'll talk about that. And then, of course, we need to incorporate any legislatively required benefit changes. So we do have a few of those to chat about today. And then also incorporating health equity into the considerations and decision-making process. Okay, so where we typically start, and this should be a familiar layout for many of you, because I think all of you were here at last year's renewal as well. So, yeah, as I said, what we want to make sure is each carrier is offering a competitive renewal position and is, working to meet the 3.4% target on their own. But also what we're held to is an overall 3.4% target. And how we look at that is, a weighted average among all the different plans. And then that's what we've got highlighted there in yellow is where we are in a composite basis. So these are all the preliminary renewal positions for each carrier. One thing that we have pointed out in the bullets here is that these are renewal positions that are before we take into account any changes in insurance taxes and fees. And the reason we do that, and I think most of you know this, but just I'll reiterate for anyone new who's listening, is that if the federal or state government assesses a brand new insurance tax, of 1 or 2%, that obviously eats into the 3.4% target. And so we sort of got the permission to exclude the impact of that change in taxes and fees from the renewal calculation. So the good news about this year, though, is that there really aren't huge changes in the taxes and fees. And so the actual renewal position is going to be very similar to what is shown here. And we'll explain that a little bit more as we get into the details. But real quickly, you can see that, again, these are preliminary, but Moda is at 4.4. Kaiser is higher this year at 6%. We have a slight decrease from Delta Dental. No change in rates from Kaiser and Willamette Dental. The Moda Vision, which again, which is a decrease in rates, and then the Kaiser Vision is increased, but a little bit lower than the target. And all of that puts us at 4.1. Overall, I think it's a good place to start the renewal discussions as we head into the year, because there's more work to be done with the carriers and certainly many options to consider. But are there any questions on this before we get into the details? Okay. So I think we can move forward, and I believe I'm going to pass this on to Jesse.
Hi, everyone. This is Jesse. Hopefully you can hear me. Rose, go ahead and go to 7. So we're going to go first through Kaiser, their preliminary renewal. And the earlier slide 6 said 6.0%. We're going to get one level lower and 5.99% here. As Jenny mentioned, the change in federal taxes and fees was really de minimis this year, especially for Kaiser. I think it was like a penny. because it was a partial year tax. So we didn't want to ignore it. So we put it here as far out as the decimals as we needed to, but it's still 5.99% after that as well. So then the other observations we've summarized here are just that Kaiser does some pooling, and the 1.9 million of claims was taken out and replaced with a pooling charge at a pooling point of 750,000. There's an annual trend assumption of 5.97% they're using. Administrative cost increase of I guess fairly reasonable 2%, given inflationary environment I think we're aware of. And then the rate stabilization reserve, the RSR fund balance as of October is 15.1 million, which represents 8% of the Kaiser premium. So pretty meaningful amount of money there. And then the just a note there that the board last year approved Kaiser using some of the funds for some wellness activities. So that's the status quo. If we can go to the next one, we're going to look at options for plan design. I shouldn't say options. This one is actually a book of business change for Kaiser to comply with the Oregon's essential health benefits requirements. So this they talked through on last month's board meeting. You may remember around these alternative care categories: acupuncture, chiropractic, and naturopathic. So this is just a little bit of a recap of that. It has a pretty small negative rate impact, so that's good in a sense. It helps us with that big 6% increase, but basically it's split into two parts: acupuncture, chiropractic, having some changes where it's becoming, instead of a dollar cap, it's a visit limit. And then in the case of naturopathic, again, it's dollar cap going away. And the visits, or I should say the benefit counting more as a core benefit offering. So neither dollar maximum allowance or visit limits. And then it's treated with standard cost sharing. So that was the one mandated plan change by Kaiser. Any question?
Yeah, does this mean that the minus 1.4% has been included in that 5.99 or hasn't?
It is included.
It is included. Thank you.
So sorry, I guess I misspoke.
No, that's fine.
Helps. It does help. It just helps us get to 5.99.
Got it. Thank you.
Good question. Thank you. If I remember right, I think there might have even been some takeaways from the January meeting, or some action items to kind of get a little more information. And this will also be part of our this is the preliminary results. It's kind of just what we've received so far, but we are having discussions with Kaiser about this and the other items on the next slide. So unless there's other questions, yeah, thank you. So here, this is sort of our options for how to take it from 6%, 5.99 to 3.4, including some optional benefit changes they've proposed. And so the first is for pharmacy copayments, generics, taking those from $5 to $10, pretty meaningful rate impact, minus 0.8%, very helpful. And then the increase the maximum out-of-pocket limit, even more meaningful, minus 1.5%. So those are the plan changes you could consider. And then the other is the RSR funds that are available. We should probably also note that we do have a list of items that we've started to talk through with Kaiser after our actuaries reviewed the renewal, and there may be an opportunity there to see a little bit of movement. But we wanted to talk about the RSR funds and see if there are any questions on that, because I think the next step is to look at Moda, where last year Moda we did use RSR funds, and
Yeah.
the pros and cons of that.
Real quick though, I will just point out that the pharmacy copayment changing from $5 to $10 certainly is just an option, but what we did see in the benchmarking is that the $5 pharmacy copayment for Kaiser on those generics is better than benchmark. So that is something to consider. The increase on the maximum out of pocket, I believe, is just on plan 1. And, you know, certainly we just asked Kaiser for some options to help us reduce the renewal, just for your consideration, but perhaps doesn't align with, you know, some of the other goals to help lower out-of-pocket limits. Now, plan 1 is a pretty generous plan, and so we could take a little bit more, we could talk a little bit more about that. I think the purpose of giving you all some options to think about is to try to get your feedback and understand, you know, which of these options you'd like us to continue to bring back to the board for renewal consideration in the future. The rate stabilization fund, certainly there's a, as Jesse was saying, there's a pretty healthy buildup on the Kaiser side of that. It's, you know, if you use that as your sole way to get from 6% down to 3.4, you know, that then you're going to have a harder time meeting your renewal target in the following year. But we'll help you walk through all of that. And again, this is a preliminary renewal at this time.
Tom, you have a question?
Yeah, you didn't include us going in the time machine and going back to last year where we approved less than 0. And if you remember, my conversation and my concerns last year was that with a relatively small group of members, 30,000, you're going to have volatility. And now we've had some volatility, and it is the craziness of having to meet 3.4% every year tells us we should be having 3.4% every year, even for the years where the numbers would suggest being able to get away with a lower number. And so I told you so. At least and here it is, aiming right at our rear end.
No, you're exactly right. Yep. I would say though that you know, we're having discussions with Kaiser, and you know, the fact that they're applying a 6% trend during this time is something that we're having pointed conversations about.
So I just wanted to add that our starting point is at trend. Really, what they're offering us is a trend increase to start.
Jeff, can you explain that for the rest of us? So,
well, if you go back a couple pages, essentially their trend, I think, was 5.75.
Yes.
And they're coming in at 5.99999%.
Yes.
You know, effectively, that's what the overall cost of business is for their nominal population. So, you know, there's more discussions to be had. Kaiser definitely is largely rated on a pooled basis with modification for our subdivision. And so seems like every year in the past, our consultants have been successful in negotiating that downward. So this is the first pass, right?
Yeah, that's correct. And you're exactly right, Jeff. I mean, Kaiser is using essentially a 6% trend, which is what they're applying to their entire book of business. What we presented back in, was it January or December? I mean, OEBB's specific trend with Kaiser is certainly much lower than that. I think where we're all trying to get at is, you know, looking into the future and what does the future look like in terms of utilization and cost post-pandemic. Hopefully, hopefully this October qualifies as post-pandemic, but that's what we're all trying to figure out. And, you know, again, we're quite a bit with Kaiser, and we're good partners. They're good partners of OEBB's, but you know, at the end of the day, we want to make sure that they're not being overly conservative in their position.
So I agree with Tom. We're being asked to walk a tightrope on costs, and it's challenging.
So Jenny, I have a question. I know I'm going to get this question from OEA members. So if you could address the administrative cost increase of 2%.
Well, on administrative fees, that's not necessarily unusual to have a 2% increase. When you start getting higher than 2% on administration, that's where we start to ask a lot of questions.
Okay, thanks.
Any other questions? I think we can go to Moda, the slide 11, and 10's the cover slide. Yeah.
Okay.
Jenny, did you want to?
Sure.
Explain the history.
Yeah. We don't have Brad here today. He's on vacation, so I'm playing the part of the actuary, really. But the purpose of showing you this slide is just to talk a little bit about using what the impact of using Rsr funds to buy down a rate, and what is the impact of that. So last year, the board did decide to use rate stabilization funds to reduce the Moda rate by about 0.5%. And so what this chart is explaining is that while we just mentioned to you that the proposed renewal is 4.41, had we not opted to use that rate buy down, our preliminary renewal at this point in time would be 3.89%. Okay, so that's just, you want to keep that in mind as we think about using rate stabilization reserve funds. But if we go to the next slide, I'll give you a little bit more of a breakdown. So in the yellow is where we're really starting with Moda. We ask them each year to calculate the renewal and show us how they do that, as if no changes were happening. If the buy down didn't happen, if the legislative changes and in some cases taxes and fees didn't happen, what would be that rate change? And in the yellow or gold, that's where we are. So the calculated renewal that Moda is coming up with, just assuming status quo, everything stays the same, is really 3.11%. So that's below our 3.4% target. However, we do need to add in that the impact of the rate stabilization buy down of 0.5%. And we're adding in just about a little under 1% for some benefit changes that are required by the state or federal government. And so when we add all of those things together, we're getting to the 4.41%. So hopefully that gives you a little bit more understanding about the rate. Again, this is a preliminary renewal from Moda. We have several areas of their renewal that we're continuing to discuss, and it's appropriate to do that, and it's not unexpected to be a bit conservative at this early stage of the renewal discussions.
All right, I think we're ready to go to questions, or ready to go to 13.
Yep.
So this is the renewal summary for Moda, sort of like we did Kaiser earlier. 4.41% was what the roll-up slide showed for the Moda medical component. Changes in federal taxes and fees, a little more material than Kaiser's, but still pretty de minimis. So it doesn't do a whole lot to the end renewal as far as preliminary goes. Their trend assumption is 4.58% when blended. It's split into a medical trend of about a little over 3% and a much higher pharmacy trend of about 10%. So those are the component assumptions. There is still an explicit COVID margin of not a whole lot, 0.25%. General margin 1%, and then using plan experience of the plan year prior to the current one. And then I think Jenny knows there's, and I think everyone knows probably even better than I do, that there's the renewals will be updated with more recent claims in the coming weeks. And then proposed increase to administrative fees of 3%. And Jenny, you just said earlier about the 2% not being pretty reasonable, and then above 2%, we start to ask questions. I think we started to ask questions in some of our conversations with Moda on that. So we're on top of that one. And then state mandated benefit changes. So these are detailed in the appendix. So it's actually the very last slide. And it's actually a pretty meaningful amount, 0.8% increase. And we can go through those if needed. They're, like it says, mandated by the state. The next one is federally mandated change. And this is the virtual care visits during the pandemic period. We're allowed to, under a high deductible plan, you were allowed to basically ignore the deductible rule for high deductible plans. So that goes away. That went away or will go away at the end of the plan year for OEB. And the impact of that going away is really a less favorable plan design for members. And it's worth actually not a whole lot, minus 0.02%. But we wanted to capture that here as a mandated change. And those two components, because they're mandated, are included in the 4.41% above. And then the RSR balance projected to September of later this year is 21 million. So it's more than Kaiser, but less than Kaiser as a percent of premium, because there is quite a bit more premium in the Moda plans. And we actually have a sub-bullet there just noting that in order to get from the 4.41% to the 3.4% target, you'd need to use 6.2 million of the RSR funds, kind of absent any other changes or the renewal changes with more claims or negotiation. So that'll give you a sense of how much it would take to kind of get us that 1% or so that needs to go down to get to 3.4%. Any questions? It looks like there's a question.
Yes, Holly.
Thanks, Robert. Just wondering, would medical inflation be captured in the administrative fee line item or bucket, or would it be somewhere else?
So like Jenny, go ahead if you.
Well, I mean, that's the classic "it depends" answer. So medical inflation, right, is gonna at the end of the day flow through claims. It's the combination of both utilization and unit cost. So let's just say a hospital, needs to increase their, salaries, and they have other inflationary costs, and that, if that's closer to CPI at 5-6%, then that's eventually going to flow through negotiations with the vendors and claims. It's a little bit more overt, or should be known in a program like Kaiser, where they understand what their costs are and they understand where, the revenue from premium comes from. So they can manage that a little bit more closely than, a Moda who's working with lots and lots of different hospital and providers. Does that answer your question, Ollie?
Yeah, I mean, I'm kind of getting to the same conclusion as Tom earlier regarding the 3.4%, and when there are circumstances like out of this world inflation and that you're dealing with, it seems like an exception would be in order, but no, that is helpful. Thank you.
Well, I think what this may be highlighting, and what Dr. Siltebo brought up earlier, is that when you have a year where it's appropriate to pass on a rate decrease, and then you have to go for a little bit higher than 3.4, or in this case maybe it's more than a little, but there isn't any credit for that. So it does seem like it would be nice to look at a longer period of time and more of maybe a rolling calculation. But that said, let's just say, right now inflation is higher. And if Kaiser, I'm going to pick on Kaiser a little bit, because if Kaiser sort of says, well, we need the 6% trend to kind of address that, they're now essentially establishing a new baseline. So now our costs are here, and now they're up here. And then are they going to still continue to trend at 6%? Are they going to continue to trend at 3% like they did before? and what's the combined impact of that. So those are the things that we talk with them about.
Thank you.
Okay, I think, oh, go ahead, Tom.
Yeah, it'd be helpful actually to have for us to understand this, is we should be looking at both of our medical providers and see what their increase has been over the last 5 years, so that we actually have some, so we actually know what's been going on. I think that would be very helpful for me. Also, if we were going to have and it also should be on the same graph, we should have a commercial, what the average commercial change has been, if that data is available, and what CPI has been, because I think we're stuck right now at a 3.4, and we don't know what's going to be happening for inflation, general inflation, and the 3.4 may result in the product we offer to our members really tanking over the next several years, as we are forced by law to meet that number. And I think we need to be starting now to prepare the presentation to the legislature around this issue because I think OEBB has done wonderful job, and Moda and Kaiser Permanente have done a wonderful job, at least during my 5 years that I've been on the board, and actually almost 6 now. So I think that would be a very helpful bit of information for us to start calculating. Thank you.
Jeff.
Here we go. Programs that we've done in the past for managing costs recently to accountable care organizations, our current focus on centers of excellence, are all intended to drive us below book of business trend. And so rather than have to face maybe some substantial cutbacks in the actual benefits, it's just important for us to stay the course on looking at ways to build more efficiency and manage our costs that way.
Anyone else at this point? Oh, Tom, yeah.
Yeah, I want to respond to that. I mean, I think that, I don't know if all of you know, but I'm on a statewide group called Value-Based Purchasing Work Group. And the idea is to try to move the state to a area, more coordinated care, more risk that the delivery systems move away from volume and move towards value. And the problem here is that Kaiser Permanente is the end state. It's not the, so like when we talk about centers of excellence and things like that, and site of care work for pharmacy, Kaiser Permanente has been doing that. So, so they're, again, I don't know anything about what's in that 6%, and I think Jeff is very appropriately saying, hey, that looks like their general trend. So we'll have to see what their utilization and all of that, whether or not that's hitting into. But again, let's look at what's been happening for a 5-year period of time, and see what's happened there. But inflation is inflation, and I don't think we've kind of skated the 3.4 because we've just gone through incredibly long period of time of relatively low general inflation, and it's not clear that we're going to have that ongoing. So that's my worry.
Bob.
First a question and then a comment. Remind me, and you probably said this earlier in the meeting and I just missed it. What was our RSR balance a year ago at this time?
It's not too different on Moda or on Kaiser. Let's just, we used, what is it? Where's our RSR deal on here? It's 21 million here. And we used about 0.5% of premium in this current year to buy it down. So it was a little bit higher. And then on the Kaiser side, gosh, what was it? Like 15 million?
Well, it was 10 million a year or two ago, and then it popped up to 15, and then they used a little bit to lower the to pay for these additional clinics. And
yeah, the Kaiser right now is 15 million. We did use, you know, $750,000 to fund some wellness programs for the next 3 years. But right now, going into this new renewal time, we've got 15 million on Kaiser and 21 on Moda.
Okay, so here's my comment. This is not unlike school district budgeting. Reserve funds are looked at closely, and reserve funds are looked at in terms of they could be used to lower something, they could be used to buy something, and I would just suggest to us that we need to have a strategy around what those reserve funds are for and what we are willing to spend them on. And because we're not going to buy down the rate, then what's the alternative? What are we saving that money for? Okay. So that my second comment is, like most of you have said, this train has been on the tracks for a while, and pretty good chance that it's going to get worse before it gets better because of the inflation factors in our country, and cost of labor is rapidly rising everywhere. And we've got to figure out a way to get relief on it, because the only possibility going forward is we transfer more of the costs of healthcare to the employees. Tom, you mentioned this in a previous meeting about the deductibles and how high they are and how much out of pocket people spend. And so we need to have our overall thinking prepared to go to the legislature and say, this is why this is not going to work.
Great comment, Bob. Ali.
Oh, just briefly, I agree. Great comments, Bob. We do have on the work plan for the OEBB board a reserve policy discussion for this summer. I think you're exactly right, and that's actually one of the areas the auditors identified, and especially as we accumulate reserves. One comment also on the statewide cost growth group that Tom works closely with on the VBP compact. It does look like they're moving towards, I think they've identified 3.4% as well, but more of a flexibility within that cap. So that's still down the road, and I don't want to get out in front of them or speak for them, but that there is hope down the road in the near future of a cap with a lot more flexibility around unforeseen circumstances and that kind of thing.
Okay, thanks, Holly. Anybody else at this point? Thank you for your patience on our questions, comments. Continue.
Yep.
Okay, I think we're ready for slide 14. This one looks at plan changes. So these are proposed or optional plan changes that you have a decision to make on, in contrast to the list that's in the appendix that's the mandated one. So these are optional. The first, it's a little confusing because a couple of these relate to Oregon mandates, state mandates that are being sunset. So the first two, prostate screenings, basically prostate specific antigen screening test, and PREs or DREs. These, under the prior Oregon mandate that is being sunset, were covered annually. The proposal is to change these to be every 2 years for those age 50 plus, or as recommended by provider if high risk, if there's a clinical reason to do so. This has no rate impact, interestingly, just moving it from every 1 year to 2 years. And I'll just say, this is we check with our clinicians on this one. This is and maybe it's not news to the folks on the board. PSAs are kind of a tricky screening in terms of clinical guidelines, and we have a lot of clients who go by the U.S. Preventive Services Task Force list, and there's a little bit of, I guess that list has changed over the years, but these tests are not universally mandated, universally recommended, and so we just wanted to put that out there as you're considering this change. Like I said, it has no rate impact in what Moda is proposed here, in moving to just offering it every 2 years for age 50 plus. Did any questions on that one? Because that one was a little, the other ones we were a little more clear cut on in recommending or being comfortable with, but wanted to pause there and give the opportunity to discuss or ask questions.
Reed.
Thank you, Robert. So can everyone hear me? Yes.
Yes.
Thank you. I've had tech problems all day. So if there's no rate change, you're saying that this change is due to a recommendation of best practices?
It's Moda's proposed change.
I mean, this is where, there's probably 3 or 4 physicians on the call who can also answer this, but what's happening, the PSA test in particular has been met with a little bit of controversy, just because sometimes you'll get we'll get a PSA test and the treatment isn't really different depending on the result of the test. Now that's in a lot of cases. In some cases, you will find that you have some sort of an aggressive cancer and you do need to treat it. But what I think Jesse and Moda are saying is that the recommendations for how frequently we would recommend, or that a plan would recommend having someone have this test, are changing. And so it may be prudent to go ahead and change the underlying plan design as well. Does that seem to, I don't know, I might call on.
This is Tom. I'm very surprised that you would have that type of granularity in a plan design. This is something between physicians and their patients. So I would just stay away. I would make any change and it has no rate impact, and let's move on, because it is very complicated, and whether or not it's 1 year or 2 years, and all the risk factors and life expectancy, on and on and on. We could spend, I've been in day-long conferences where we debated this. So this isn't the place. If it's zero impact, let's just go to the next one. My recommendation.
Okay.
Sounds good.
Okay. Unless there's any others, I'll keep going through the easier ones. The next one does have a slight negative rate impact. This is another Oregon mandate that is being sunset, where there was no cost sharing on management of diabetes for the mother from conception through 6 weeks postpartum. That Oregon mandate is being sunset, as it notes, and the no cost sharing will be lifted. Thus, regular cost sharing will apply again with the new plan year. We're comfortable, I guess, in checking with our clinicians, we're comfortable with that change, but wanted to open it up if there are any other perspectives or discussion. If not, we can. Oh, go ahead.
This is Tom again. There's no particular reason to identify diabetes as compared to any other medical condition that you would want to have this no cost sharing. So if we have a system of insurance that has cost sharing, diabetes should be included in it.
Okay. And then the next one, diabetes, this is testing supplies and continuous glucose monitors. This would be restricting coverage to just being under the pharmacy benefit. So removing medical benefit coverage for that. Right now it's covered under both. This has a negative 0.05% in rate impact.
And kind of the reason for that is that, you know, Moda has more advantageous pricing under the pharmacy benefit. And so it just means at the end of the day, savings for both the plan and the member.
Okay, the next, unless there's any questions, the next one is the site of care expansion, and this is around oncology medications. So Moda has had a program up to this point that has included non-therapeutic medications around oncology care. I think it's more in the realm of palliative. But now they're moving into therapeutic oncology medications, and this has a minus 0.1% rate impact. This is their gradual rollout of their site of care program, and I think in the past, you know, we've been supportive of this, and I think this is the right direction to go, but I wanted to see if there's any questions or discussion we want to have. No?
Yeah, this is Tom again. This is something we need to do. This will be, this is part of a multi-year rollout in terms of addressing the issues of the most cost-efficient and safe way to administer medication, all medication.
Okay, thanks. The next one is a cost increase, proposed cost increase, where we remove the maximum cost share from plans 1 through 5. This is again optional, purely optional, and then the effect of that would be all pharmacy cost sharing would accrue towards the medical out-of-pocket maximum. So this is a sizable design improvement. So the rate impact is an increase of 0.7%. And that one is actually overwhelming the other pretty smaller design rate impacts and kind of driving the total below 0.53% to be an increase.
Yeah.
It's a question.
Reed.
Yeah, thank you. So for that last one, was there discussion about changing the maximum cost share instead of eliminating it altogether?
Yeah, last month we talked a little bit about what would it look like to reduce the maximum out-of-pocket level on the medical plans, and also what would it look like to, or how is it impacting having the max cost share? So if you remember, the max cost share is something in addition to the medical maximum out-of-pocket, and essentially pharmacy cost sharing accrues to that separate max cost share. And then some other things like the additional cost tier or out-of-network services, all of those kinds of things. The one thing that we did highlight at the last meeting was that there's about 250 members in the last plan year who met this max cost share limit. So what we're talking about here is just, and again, you know, this is just an option. It's certainly just something that was discussed as something we wanted to explore, so we wanted to price it for you. So this would only impact plans 1 through 5, and it looks like about 250 members would benefit from that. Of course, that can change from year to year depending on how people use healthcare. But
thank you, Jenny. I wasn't able to attend all of the meeting last month, so I appreciate the recap.
No worries.
Tom?
Yeah, and so with this one, are we out of line with what's offered and available in the community? I don't remember that. I know that we've had conversations around how our out-of-pocket maximum has been on the high end, and it sounds like with the maximum cost share, it's the it sounds like what we've had is kind of a double whammy in that while we have high medical out-of-pocket maximums, then we also have a situation where we're not counting pharmacy and other components into that. So I'm trying to understand it a little bit better.
Yeah. Well, it is a little unusual to have both a medical maximum out of pocket and then this separate max cost share. Now, what the max cost share is just ensuring is that we're meeting the federal requirement that a member shouldn't pay more than, you know, what they set forth, and that's what the max cost share has been set at. What we may want to do just at the next meeting is kind of show you, just remind you what the plan designs look like for pharmacy, because on the pharmacy, most of the cost sharing, there's a minimum and there's a maximum co-payment for each prescription for either a 30 or a 90-day supply. So there's already some built-in protections, but there are some folks who are taking very expensive medications. And I think that happens most frequently on the non-preferred side. And that's where they end up hitting their max cost share, or they have, you know, a lot of out-of-pocket costs. So we can bring that back to you next month, so that maybe that'll help you understand this a little bit better.
Any other questions? I was going to say, just recap, the 0.7% is driving the 0.53% total there. And then we've taken that 0.53% total. And again, these are all optional changes, added that to the baseline preliminary renewal for Moda of 4.41%. It takes us up to close to 5%. But again, that is really driven by that, removing that maximum cost share feature. So that's the next slide actually illustrates that 4.94% there, and takes that and applies it to the Moda Medical on the far left, 4.9%. Before that was 4. I already forgot, 4.4 or 4.5.
Yeah.
But now it's 4.9 with the 0.5% added. And then that has a material impact on the total over on the right. That was, I believe, 4.1% on that slide 5 earlier. Now it's 4.5%. So going in the wrong direction, I think, is the highlight there. But that's just to illustrate how impactful the Moda plan changes could be. So that's it for that one. Next slide. So these are optional plan changes that are still under discussion and review. They did share some information on the first couple. First being behavioral health, changes to programs there. And actually, Jenny, was I going to have you talk about this one?
That's okay. No worries. I'll just kind of jump in though and just say, you know, Moda last month talked with the board a bit about their proposed coordinated behavioral health program. It's a concept that they are still developing, and we have some questions about. So we, our plan is to have more information to share with the board at the March meeting, including the pricing and cost of that particular program. The pre-diabetes program is something we're exploring. In fact, we're going to talk more about that in detail when we go through the wellness program renewals later this afternoon. And then finally, we've been talking about the Center of Excellence program, which is still under development. You know, given the state of affairs at the hospital has slowed down some of the work that the carriers have done directly with the providers in kind of coming up with a solution. But you know, as we were talking about earlier, ways to get to your 3.4. You know, certainly benefit design change is one way, but these programs, like the ones that are listed here, are meant to, you know, increase the efficiency of the underlying program rather than, you know, reducing benefit design. Or the other way you can also kind of affect some changes to, you know, narrow down the providers the provider network that you offer to folks, to the more efficient providers. And that's kind of what a center of excellence is attempting to do. So again, these are ideas that may not have a short-term huge savings, but are meant to provide savings over the longer haul.
Any questions? Sounds like more to come.
Yeah.
Including in the next couple hours on the pre-diabetes piece.
Yeah.
Okay, next is dental. So if we go to 18, and I think we have something like 10 minutes left, maybe a little less than that, but we should be able to pick up the pace a little bit. As you can see, this is just the dental by carrier base renewal, preliminary renewal positions. Lot more favorable than the medical. So if we go to 19, we can look through each of these in parts. So Delta Dental of Oregon, kind of the dental piece of Moda, 1.1% rate decrease, administrative fees increase of 3%, dental trend, claims trend 3, general margin 3, and then just one proposed plan change with a pretty sizable premium impact of plus 3.1%, where this is taking the class 1 services, so basic preventive type services, and not having those apply to the plan year maximum. It's a popular provision change in the dental world to kind of get people to go and get their checkups and cleanings and not have it count against the maximum, because if they've got severe dental needs in a given year, they might forego that preventive care in the interest of saving those dollars for their more serious care, which we don't want. We want them to go in and get their checkups and cleanings. So so there's a decision to be made there, and I think we can maybe in the interest of time keep going.
Well, I'll just make one quick comment, and that is, this may be the third time that Moda has proposed this change. It is something that they tend to promote within their book of business. What we did look at in the last year or two is that it does turn out that the members on Delta Dental plans do make use of their preventive care benefits. So if the goal of this program is to encourage preventive care, we're already getting some good results under the Delta Dental program, but it does maximize the benefits, and it's a nice benefit to have, even though it's relatively an expensive one to implement. But
okay, ready to go to Kaiser next. So Kaiser's, Tom, go ahead.
It'd be helpful for us to make that decision. While it represents a 3.1%, what does that translate to the overall? If the overall, while it's a plus 3.1 for dental, it may be 0.1% for the overall total that hits at the, to get to the 3.4. So it'd just be helpful to know that at our next conversation.
Good point. We will definitely bring that back at the next meeting, or when we talk about dental next. And if we go back to the Delta Dental plan has been running extremely well over the years, and especially during the COVID year. I mean, there was a suppression in claims. So, the plan is in a very, the minimum premium arrangement for the dental is in an extremely healthy position at this point. And so, one of the things that we are talking with Moda about is, do we really need any kind of a margin in dental anyway, especially given the position of the minimum premium arrangement? So I do feel like there's some additional movement to be had on the dental plan that we'll work with Moda on. They're very workable on this. So hopefully we'll be in a position to really be able to consider that benefit enhancement at this next time.
Okay, so Kaiser has no rate change, 0%. No increase to administrative fee. We like that. Don't like the dental trend so much. I think we pushed back a little bit on that one, but more to come. And then no proposed plan benefit changes. So that was the easier one. So I'm going to actually turn the Willamette one over to Jenny to handle.
Yeah. Well, I mean, the Willamette Dental preliminary renewal proposal at the end of the day is 0. So that's good news. What's happening in the dental world, right, is over the last year or two during the pandemic is that there was, a period of time where people just couldn't get dental services because there was sort of a moratorium on that. And then even when that was lifted, folks have slowly been getting comfortable getting back into the dentist, but there are still a number of folks who don't feel comfortable in that environment right now. So we're getting back up there. But so again, all of the carriers are doing what they can to try to predict what's going to be happening and what the rate position needs to be for October and the next 12 months. So that said, just as a little bit of a reminder, because last year was a long time ago, but last year when we were having these discussions, Willamette Dental basically offered to reduce the rates for 1 year and 1 year only by about 4% because there was some surplus excess funds in the Rsr program. And with the Willamette Dental Rsr Fund, the arrangement is that there's a cap on the amount of funds that can be put into that account. So we use some of the excess RSR to kind of reduce the rates down by 4%. So members actually saw a 4% decrease, right? So this year, the expectation is, well, if we're really offering a 0, what members would see is a 4% increase, right? So we've talked with Moda or Willamette Dental quite a bit about their rate position and the way they're underwriting the program. And so at the end of the day, we did come to a nice agreement together to continue the current rate structure for another year. So not having that bounce back up by 4%. So that's where we are with Willamette Dental. I will say at the bottom of this page, we've listed a benefit enhancement that Willamette Dental originally proposed. But in the latest rounds of negotiations, they have essentially pulled that benefit enhancement offer off the table in order to continue to offer the 0 rate position. So I guess all I'd say is we'll continue to talk to Willamette Dental about whether there's room to put this offer back on the table. And other good news, Willamette Dental they are offering to continue to waive co-payments for OEB members who haven't been to a Willamette Dental facility before, just in order to encourage better rates of preventive care. And so they've reported that about 1,300 members have taken advantage of that program, and they're going to continue it. So that's a really nice offer. Any questions?
Okay, ready to go to vision. It's 23. It's actually just one slide. Could be pretty quick. Thank you. Okay, so Kaiser community rated, 3.1% increase. Moda, an actual about a 5% decrease. Good news there. And then VSP is in a 4-year rate guarantee. This is year 2 of a 4-year rate guarantee, so it's the same rate as prior year. Any questions on those? It's good news there. And then I think we have the next section is the health equity. Quick little update. Should be slide 25. And this is just prior to the renewal kickoff, we were asked by the board to ask some questions that Willis Towers Watson put together of the renewing vendors. These are the questions we asked. We do have responses from all the vendors, And we are in the process of summarizing those and can share those with you as a next step. There's a lot of content, a lot of words. So we'll do our best to summarize those and make them a little more digestible, and then you can hop to the full answers if for the topics that you want to dig into. That was the update on that one. That's it there. I think we're on the next steps. Unless there were questions.
Okay, we can go to the next steps. Or I'll just tell you what the next steps are. So, okay, the next steps are that in the March board meeting, we plan to come back to you with any clarifications on some of these options. And again, solicit some feedbacks on the ones that you know, you're interested in moving forward to the final renewal. We won't really have updated renewal figures for you unless we get something meaningful back from the carriers. But then in April, we'll come back with refined renewal positions for all of the different medical, dental, vision carriers. We'll use a little bit more experience and we'll incorporate some more of our discussions with them. And then walk through some of the options for either benefit plan changes, use of RSR, if that's something we want to do or need to do. And then if necessary, there will be a second April board meeting where we finalize, make the final decisions. Okay. Any questions?
Okay, so if no questions, we're going to shift back to Jenny on life and disability renewal considerations, and then we'll take a break after that.
Okay, so I did invite another one of my colleagues, Ben Linhard, to join. I'll take you through most of the renewal positions, but Ben is an underwriter or financial analyst with Willis Towers Watson, and he has a really strong underwriting background, has worked for 2 large life and disability carriers and helped evaluate and work with the standard on coming up with these renewal options for the board. But okay, let's go ahead and move forward. Wait a minute, there we go. Okay, so I'll walk you through the executive summary, just high level, the life and disability renewals. I mean, we usually, you know, the life and disability programs tend to have a longer life. We'll go right into it, but they have a longer life. We tend to get 4-year rate guarantees on the life and disability lines of coverage. So they come up for renewal discussion less frequently than the medical and dental. So I'll kind of walk you through high level what the rate positions are, and remind you of what the rate position was the last time we did this. And then we have several options to talk about and discuss. There's a lot of pieces and parts to it. So I'll first start with the life insurance. So basic life insurance, this is life insurance that is paid for by the employer or the entity. The standard is proposing a 15% rate reduction, and 4 years ago we also had a rate reduction, so nice news there. On the basic dependent life, no change. Basic AD&D is a 33% decrease that's being proposed. Last time around there was no change. Optional life, this is life insurance that is purchased by the employee. If the entity offers it and the employee wants to, they can select to buy additional life insurance, you know, at their own expense. We'll talk quite a bit about the optional life line today because the standard is proposing a 55% decrease in those optional life rates. Last year, and there's an error on this slide, last time around there was a 15% decrease in the optional life rates, and we talked quite a bit about some options and what the decrease should be. But the other thing that the standard offered was an open enrollment, and that means anyone had the chance to purchase additional life insurance if they hadn't before. And we increased the guarantee issue, or the amount that members could elect without health underwriting. And so because we opened up that open enrollment opportunity and increased the guarantee issue, that opens up the plan to more risk. So traditionally, you don't usually do that and go with a significant rate decrease. So we went with a moderate 15% decrease and got some new enrollment, and I'll talk a little bit more about the impact of that. The optional spouse life is last time around was a 10% decrease, and this time around we're also proposing another 10% decrease. And then no change to the optional life for children, and then the optional employee, and that was for both. That was the AD&D coverage. So the employee and spouse AD&D is getting a 25% decrease this time around. There was no change last time. Okay, so this is again executive summary level. We'll get into more detail as we talk more, but let's go to the next page. So life insurance, there are 2 claim fluctuation reserve accounts for life insurance with the standard that OEB has with the standard, and standard calls it a claim fluctuation reserve. This is really a rate stabilization reserve. It's the same thing. It's very similar. On the basic life, there isn't any balance in there today. Based on the experience that's happening, standard does project there to be a small balance at the end of this contract period. On the optional life, however, there's a significant balance right now of 8.8 million, and then another significant increase that is projected by the end of this contract period of $17.8 million. And we're going to talk quite a bit about that because the balance in this account right now at what it will be at just about 18 million is significantly higher than the amount of annual premium paid under this contract. And so we have talked with Standard about ways to apply or use those funds for members who have contributed to that surplus. And we'll talk a little bit about those. A couple of the options involve the Standard offering a critical illness policy to members who are currently or will be on the optional life plan, and that insurance policy is essentially would be paid for through the claim fluctuation reserve account. And again, I'll talk more about that in a little bit. Let's talk about disability on the next slide. Okay, disability insurance. There's 2 types of disability insurance. There's short-term disability and long-term disability, and OEB offers a variety of different plan designs. And again, we look at the plans under those plans that are paid for by the employer, and then there are some plans that are paid for entirely by the employee. And the reason that we look at them differently is that we have different claim fluctuation reserve accounts based on whether the program is employer paid or employee paid. And I'll get into that on the next slide. But for the voluntary short-term disability plan, the rate change that Standard is proposing this time is a no change whatsoever. Last time around, there's a 20% decrease. And on the employer paid side, so the next row down, again, no change proposed this time. Last time around, we didn't have a 20% decrease, so that's an error. That really should have been on the voluntary line. Secondly, the comment there about the rates being reduced by 50% 2 years ago, that applies to the voluntary short-term disability. So that's my error for putting it on the wrong row. We did that intentionally 2 years ago, even though we were in a rate guarantee period, came to the board and said, there is an Oregon paid family medical leave program coming up in it was supposed to be 2022, but then it's been extended to 2023. And so given where we were with the claim reserve account, we wanted to use up some of those funds because we anticipated that some of these short-term disability plans would no longer be necessary. So we walked the board through a few options 2 years ago, and the decision was made on the voluntary short-term disability, the employee paid side, to reduce those rates by 50%, lower than what is sort of necessary to sustain that plan, in a direct effort to use up the claim fluctuation reserve balance. And we'll talk a little bit more about that. Long-term disability, this time around, the standard is proposing a 25% decrease. Last time around, there was no changes to either the employer paid or the employee paid long-term disability. Okay. So that was a lot, although that is the high level. We'll get into a little bit more details on each one of these. Let's go ahead and go to the next slide. Oh, well, I guess this is the claim. I guess I should have mentioned this is the rate stabilization reserves for the disability plans. And so here you see we're at a deficit on the programs that are employer paid, but on the employee paid, we do have some money still in it. Even though we were trying to use it up by this time, there's still money in that claim fluctuation reserve. Okay, let's go ahead and move to the next slide. Okay. So basic life insurance, the basic life insurance, again, that's the employer paid, continues to perform better than expected. The loss ratio on the program is currently 72%. When we look at 5 years, yes, is there, Jeff, did you have a question? Oh, you're on mute.
Maybe I'm asking this question ahead of time, but we've certainly seen substantial earnings in the stock market over the last couple of years. And in life insurance and disability, there's more than one reserve. There's a claims reserve and a rate stabilization reserve. Is there any influence on their return on investment that's driving a more favorable position?
Well, I believe the claim fluctuation reserve account, those interest rates are, I think OEBB dictates what the interest rate is tied to for that. Or do you know the answer to that, David?
Yeah, Jenny, I thought I'd jump in real quick. So Jeff, on the claim fluctuation reserve account, the experience rating refund agreement dictates the interest rate that's paid on that account. Mm-hmm. And then from the actual claim reserves, there's an internal retention formula that we use, and that we've got some investment credits that we're able to then apply back towards that. But yeah, honestly, for us, although the stock market's been doing really, really well, it doesn't really impact us because we're more focused on the interest rates, and the interest rates have been really, really low. So that's actually had a detrimental impact on us when it comes to the amount of money we have to set aside.
I mean, what you're offering is good news. And I'm just thinking historically, when we first put OEBB together, the rates were below what virtually every school district was paying on their own. So we started off with a very competitive position. There was when we went out to bid, only one other carrier matched the rates that Standard was offering. And now looking at rate reductions 2 years in a row, that's kind of outside the experience I have for 30 years. So it makes me a little nervous, you know, taking the long view. It's good news. I'm just kind of paying
cautious
attention.
Yes. Well, you know, certainly the pandemic has had a dramatic effect on kind of the experience we've seen. We actually saw the disability claims really tail off during the pandemic because people were at home and they weren't out and about and doing the things they normally do. So we actually saw reductions in the amount of claims that we were seeing that we would have normally seen and had anticipated seeing. So we anticipate that will normalize, but we thought that might normalize this year and obviously in 2021, and that didn't happen. So we're still kind of struggling in that pandemic world.
And that's exactly right on the disability. On the life insurance, though, I think we have a really good, solid understanding. This is what Ben does for us on all sorts of accounts of all sizes, and so we have a pretty good sense of where the life insurance rates should be, both with standard and then, of course, compared to what we see out in the market with other carriers. So we definitely feel that the proposed decrease on the basic or on the life insurance is justified, especially the optional life.
Thank you.
Yeah. So there's a lot of comments here about loss ratio, and I realize that many of you aren't immersed in the world of insurance all the time, but the loss ratio really just has to do with the ratio between claims and premium. And so we ask the carriers what their sort of target or tolerable loss ratio is. And then we, Ben compares that with what we see with other carriers just to ensure that, the position is sustainable and competitive. Our job is to make sure that the rates that are being proposed are competitive in the marketplace, but also sustainable over the long period of time so that you don't have volatility in your rates from year to year. All that said, the basic life is performing really well. The optional life is just performing much better than expected. And we've been diving in with standard about what's driving that. And what we can see is, there's been a steady increase of lives over the history of OEB, and people aren't dying as much as we've seen other similar employer groups. So I think that's all good news, but we definitely feel like the 55% rate decrease is justifiable. There's a couple of comments here about, as I mentioned last time around, we went with a decrease in the optional life and said, okay, these are great rates. Let's open it up and let other members who haven't signed up for the optional life sign up, or they can increase the amount of coverage that they have that is guarantee issue. And that was pretty good. Not every entity makes that option available. They need to be driving that. But we did see 6,500 new members newly elect optional life insurance, and then 3,600 members increase the amount that they had previously elected. So it was a really nice result, I think, for OEB members. However, sometimes what that does is, it can make the experience, it can open you up to new risk. And so sometimes we see the experience get worse after something like that. And, that was 4 years ago. So we still may see some of that coming through. However, the experience just continues to outperform what we thought even 4 years ago. And so there's going to be another sizable deposit to that claim fluctuation reserve. And then there's a comment here about the accidental death and disability, which isn't, that can be, there's not a lot of group experience credibility on that line of coverage. I don't know, Ben, if you had any other thoughts or comments here.
No, this is all pretty much spot on. I mean, I've looked at the life going back quite a few years and from past renewals as well. It's run very well for a very long time. I mean, I think part of it is the demographics. With mostly a school district, you have a population that's highly desirable for life insurance, which is, primary females because they're at a lower risk of mortality. I think with COVID, one of the things with the first round of COVID in 2020, it was primarily a pandemic among non-working age populations. And then last year, with the newer variants, the pandemic did kind of start to hit more in the working age populations a little bit more, but it, still hasn't impacted the life experience very well. So I think the Oregon school districts have been doing very well despite the pandemic. Thank you.
Okay, so let's go ahead and move to the next slide where we can talk about some of the options. Okay, well, this is a recap of sort of the executive summary, really, but on the basic life, standards proposing the 15% decrease, and the dependent lives will remain unchanged. And we agree that this is a good and sustainable position for the basic life. One of the things that we did negotiate in partnership with the standard is, and this really also should be on the optional life as well, but reduced risk charges on the claim fluctuation reserve account. And all that just means is that it just puts more money into that claim fluctuation reserve account. The reason that we talked about that with the standard is that, this is on the optional life, if you make a decision to purposefully buy down the claim fluctuation reserve or use it up, we didn't think you want to have higher risk charges for that. Sometimes you have higher risk charges because as the claim fluctuation reserve gets lowered or decreased, then standard is taking on more risk for that. But all that to say, we just did some nice negotiation on making sure that it was a nice, efficient claim fluctuation reserve account. So let's go to the next slide. Okay, so optional life, got a couple, 3 different options to review with you. And we did review many options with the standard. So we've tried to simplify at a high level 3 of your options. And there's a few variations that we could discuss on each of these. But essentially, we think about these things like, what is the right rate for the optional life rates? And is that sustainable, right? And so we believe that the 55% rate reduction is the right rate and a competitive rate for those optional life rates now and pretty far into the future, 5 years or so. That said, we also have this pretty large balance in the claim fluctuation reserve. And you can do that in a couple of ways. One is you can sort of spend it down by by lowering the rates even further, or offering things like premium holidays, and those are certainly things we can explore. But what happens in that is once those funds run out, then you got to put the rates back to where they need to be, and that can appear like a rate increase at the time. But certainly something we can talk about. But what the options are that we have to really discuss with you today are, one, you can just go ahead and take that 55% rate reduction on the optional life and don't do anything else, and just know that you'll have a claim fluctuation balance for a long period of time to help offset any rate increases that come your way. But what you can see here is that puts you out for more than 8 years into the future. So it's a really long stability for that. Option B and C say, well, we like that rate reduction, but what else can we do with the money in the claim fluctuation reserve? And one proposal that the standard had was to offer or pay for a critical illness insurance policy using money out of the claim fluctuation reserve. And the idea behind that is, as David presented, I think it was in December, cancer and some other critical illnesses are one reason, that contribute to not only disability, but the life insurance claims. And so a critical illness policy can provide folks a benefit for some of the things that drive your claims. So a critical illness policy, and I'll explain more about what that is on the next slide, but it's essentially, like a cancer policy. So it pays somebody when you have a critical illness like cancer or a heart attack. So option B is that the standard would provide this $10,000 critical illness policy for employees and their children, and that policy would essentially be paid for out of the claim fluctuation reserve account. And what you can see here is that, that will reduce the claim fluctuation reserve account, but there'll still be money at the end of the day after 4 years and even after 8 years. So it's a pretty nice, long, sustainable option. Option C is like, well, we like that critical illness policy, but we'd like to make sure that the spouse also has coverage in addition to the employee. So this would provide a policy for the employee, spouse, and their children for that critical illness, and again, would be paid for out of the claim fluctuation reserve. What that does is you still have a balance after 4 years. After 8 years, you would have used it up on that critical illness policy. And to use, and then what we did on the rate side for the optional life is just to have the 45% rate reduction instead of the 55%. And what that does is just contributes to the CFR over the 8 years, I guess.
So Jenny, can you comment on the negative 1.8? What that means for us, whoever's still here in 8 years?
Well, I think what we would tell you is that, you know, a lot can happen in 4 or 5 years. First of all, we're still talking with the standard about trying to ensure a 5-year period instead of a 4-year, so it's still under discussion. I mean, and then what we would say is, you know, it may be prudent, you know, to market these insurance lines of coverage at some point in OEB's future. And, you know, so between the 4-year mark and the 8-year mark, you could certainly take the program out to market, ensure a competitive price, and I would imagine that you wouldn't have to worry about the claim fluctuation reserve at that point.
Thanks. Jeff?
Well, I'm a little dumbfounded that even reducing the rates 55% ends up with an increasing CFR balance. And so, I mean, I think that's great. Just that it's outside my 30 years in consulting to see something so dramatic following a rate reduction. The concern I have over B and C is you're starting to spend money on a new program that ultimately you'll have to discontinue. Even though most of us will be gone, we're leaving a benefit that is projected to run out of money. So especially in an organization like this, giving and taking away is something to be avoided, in my opinion. The third thing is, with all of the negotiations that have gone on since inception, I'm kind of curious what we actually hope to achieve by going out to bid. This is so tied to our actual experience and has a high degree of accounting and accountability. It seems like, if anything, we stand to lose some reserves, and starting over again starts the whole credibility, experience gaining and all that, starts the clock over, and it looks like it's working pretty darn well in our favor. So maybe I'm missing something here, but you know, between David and is it Leonard as your first name, or Benjamin?
That's my last name. My name's Ben. Thank you.
Thank you. So I'd like your comments on at least marketing. What we, you know, this is such a large group with so much, our risk is so big. Are we really positioned to gain anything? I'll stop there.
You want me to answer that, Jeff?
No, I don't know if Ben, you have, I mean, I guess I'll start and Ben, you can add in, but you know, when you go to market on a program like life insurance and disability, there are definitely people who will come in and be more competitive. But I think to your point, Jeff, what you want is that competitive position to stay for a long period of time so that people aren't you know, inconvenienced when they're changing sorts of things. I mean, the life insurance and disability is a little bit easier on the member's experience, right? Because they just need to, I mean, a lot of people don't even notice their disability insurer. On the life insurance, you're just going to select a new vendor. But it's a lot of work for OEB staff, for sure, to make a switch like that. But I think that's what you're getting at. What we're trying to do is to make sure you have a very competitive position and
Sure.
not have too much claim fluctuation sitting on the book. So, but in terms of marketing, Ben, you know, I'm not sure if you have any additional commentary on what kind of savings we typically see when we take these things out to market.
Yeah, I mean, I think right now we've negotiated a very good savings position with Standard right now. So I don't think we're saying market it right now either. We're talking about 8 years in the future when if we went with that option C there, you know, what we would do about the negative balance. And then it's important to remember too that the numbers at the bottom are just projections. There's a million things that are involved in just projections, from interest rates to, you know, the mortality and how people are living and, you know, those sort of things, how many claims we get. And to also, and it kind of plays in the answer to the first question that was received too, is why is the balance going to be higher after 8 years compared to what is now? And that's all primarily from interest being deposited into the CFR. So basically that 55% is your bare minimum level that you need to sustain the thing at the right, sustain the optional life account at the right level. And then if you're getting the interest on the CFR, that's why their balance is going to keep growing after 8 years. But again, if interest rates right now are at a rock bottom and they're going to go up as they keep talking about, you know, that balance in 8 years could be a lot higher. So there's just basically a million things that could happen between now and 8 years. I think we're just saying the marketing would be something to consider if we couldn't get favorable renewal terms that protects, you know, continues that critical illness benefit and keeps the rates at optional life rates at a favorable level for the employees. Thank you.
Although I guess I would say, David, I don't know if you have any other comments on that. Happy to hear that.
No, yeah, I agree completely with Ben saying. I mean, there are, you know, the experience has been running incredibly favorably for the last basically, you know, 4 to 6 years. That doesn't mean that you couldn't see a shift. And so certainly while we expect to see interest rates come up, that interest rate environment come up, which means that the, you know, the interest that you get paid on that claim fluctuation reserve account increases, you could also see the life insurance experience worsen. So we certainly saw that in the beginning. You know, when we put this in play back in 2009, we had some pretty terrible years in the first few years. So it's cyclical. You know, in the end, what we're trying to do is keep, you know, maybe your experience is going to go bumping up and down, but that claim fluctuation reserve account helps it so that it's kind of normalized and that you don't see spikes in rates one way or the other. And so we've just seen an incredibly favorable last 4 years is kind of why we're in this position we're in today.
So it seems to me a rule of thumb on optional or voluntary life programs is not to put yourself in a position where you might have a rate increase. And because experience in the industry is that when you have rates that go up, you lose participation and you don't recapture them later. So stability. So I think option A is a pretty strong option. And it's a very substantial decrease in the rates, which provides immediate savings. We review it again in 4 years. You can drop the rate some more. Obviously, the last time we dropped rates wasn't enough, but 55%, you know, dropping rates in half is pretty nice. Anyway, that's my opinion.
JJ.
Have we looked at changing the rates on the spouse rate change? It says minus 10%. Have we asked them about changing the rates on that as a way to offset some of this substantive rate reserve?
We could certainly consider that. Oh, sorry. Go ahead, Jenny.
I was just going to say same thing, Ben. Go ahead.
Yeah, we could certainly consider that. I mean, the pen's really in your hands, how we want to divvy out the rate decreases. I mean, there's not necessarily a right or wrong option. There's really just a total dollars that we can do it and how you divide that out, whether that's rate reductions, paying for a critical illness benefit for all the employees, all sorts of things. I would say the spouse has not run quite as well as the employee. One of the things with school districts is that, you know, when you have a high female population, they tend to have spouses who might be engaged in more riskier occupations. So it's just something you tend to see where the spouse life in school districts just doesn't run as well as the employees. But yeah, and the other thing with spouse life too is that we just don't know what the spouses are doing all day, Monday through Friday. So that just increases the risk on the spouse life too and makes it hard to predict what it'll look like in the future. So we don't recommend taking as much drastic action on the spouse life either for a lot of the reasons that Jeff has cited. Thank you.
Okay, I had a couple of hands, but I think they went back down, so we can continue.
I have a hand up.
Tom, it's not showing up, sorry.
Yeah, it's okay. My concern is adding benefits, as Jeff had talked about. Life insurance is easily understandable. Critical illness benefits, it doesn't seem to fit in with life insurance. So I like the idea of option A, and I like what JJ just mentioned. Are there additional things that we can do within the either the rates for spouses, if we need to lower that, after 4 years, 18.6 million.
Okay, Reed.
Thanks, Robert. I'm just wondering, have we received inquiries about this critical illness benefit from people who are currently getting their life insurance benefit?
I'm not aware. I don't know, Ollie, if you are. I mean, I think a lot of the districts may offer their own critical illness policies out there that folks are paying for, but
Yeah, I haven't heard of any inquiries, but I can definitely check with other staff.
Let me ask one more question of David. So the reserve fund goes across the member and spouses and children, right? It's all one pool.
Yes, that's correct. Yeah, the employee paid piece, yes.
So I would support JJ's suggestion that maybe a little more aggressive reduction on the spousal rate would be in order.
Hey, Jenny, if you can come back to us at a later date on that, that'd be great.
we will do it.
Thanks.
Okay, let's move on. Oh, this is just an explanation of what a critical illness policy is. So it sounds like there's a little bit more interest in not going this route, but just in case you want to learn more about critical illness policies, here's a nice slide. It's essentially the person gets an insurance policy. If the member is diagnosed with one of these conditions, then they would essentially just get money paid out to them. And the idea is that it should help them offset, some of their medical expenses. It doesn't matter if the person's on a Moda or Kaiser plan. It can be, they can have whatever medical insurance that they have, and it's not necessarily tied to the medical insurance. The one thing it does come with is a wellness benefit, where, if a member goes and gets a preventive screening, then they can just file and say, I did my preventive screening, and they'll get a $50 reimbursement, which is kind of a nice thing. There is a lower benefit for the spouse and children, but so in case you are interested in exploring that, this is a little bit more information. But let's go ahead and go to the next slide.
I'm sorry, Jenny, one last question.
Yes,
this would
sure.
only be offered to those that are participating in the optional life. Is that correct?
Exactly. Mm-hmm.
So I could see some tension occurring downstream where the haves and the have-nots. Anyway, my 2 cents.
That is no problem. On the accidental death and disability, the standard is proposed a rate decrease of 33%, which sounds like a lot, but I think, David, what are we talking about, like a penny or something, like a half a penny or something like that?
Yeah, we're essentially talking a half a penny.
Yeah.
Yeah.
So it's, looks like a lot, but it's not really a big, there's not really a big premium rate for this particular deal. But the AD&D for on the optional side for employees and spouses would also be reduced by 25%. So all in all, a nice position for this benefit if people elect it. Okay, let's go to the next slide. These are just our recommendations. So we've talked a little bit about some of the options, but essentially we're, recommending all of the different rate proposals by the standard. Although we were recommending B or C, certainly we can go back and take a look at what it would look like to reduce the spouse optional life a little bit more. Okay, and again, we are, the standard did propose a 4-year time period. We would prefer a 5-year period, so we'll still talk to them about that. But otherwise we like where we landed with the standard. So let's go ahead and go to the next slide. Okay, so this is some plan performance on the short-term disability. And Ben, we may want you to kind of weigh in on this as well, but the short-term disability, again, in 2020, we were looking ahead and saying, hey, this Oregon Paid Family Medical Leave program is coming. And based on the plan designs offered by OEBB, most of those plan designs on the short-term disability aren't really going to be that relevant once the Oregon Paid Family Medical Leave comes into effect, because that benefit would be pretty much as good or better than what OEBB is offering. And so on the employee paid side, we noticed, that we still had some claim fluctuation reserve or some reserve dollars. And so if this whole short-term disability program is going away, we want to try to use up some of those funds. And so the idea was to take the employee paid rates down further than they needed to be to try to use up some of those funds. But all in all, as David was saying, during the pandemic, folks just haven't been out and about as much. And so the short-term disability claims in particular, we didn't see as many of them. So the experience has been running even better than we thought last 4 years ago. So that's where we are with short-term disability. I don't know, Ben, if you have any other kind of thoughts or comments on this.
No further comments, but as long as school districts continue to work from home, and that varies by school district, I would expect to see the STD to continue to run more favorably than expected, which could impact our plans to draw down the CFR prior to the rollout of the Oregon PFML, which is currently expected for September of 2023.
Okay, let's go to the next slide. It's taking a little while to catch up, it looks like. Okay. Long-term disability. Long-term disability right now is performing a little bit better than expected. Although when we looked at this 4 years ago, that wasn't quite the case, especially on the employer paid side. But recently, the LTD has been doing a little bit better, especially on the employee paid side. So Standard is proposing a 25% rate decrease to the employee paid rates, no change to the employer paid rates, and those would be guaranteed for 4 years. Any questions on that?
Susan Miller.
Thanks, Robert. I just wanted to ask, there's no intention for school workers to be working remotely. I mean, the intent is to be fully functional in the schools. So at least for the workers that I represent, we are fully working on site. So there's not, any of the remote work is mostly gone. But I also wanted to ask about, Jenny, when you were talking about the family leave, the implementation of that has been put off till 2023, correct? And we're already seeing Washington's defunded. So anything could happen there, right?
Anything could happen. Right now, it says it's effective September 3rd of 2023. And so, unless they pull back for some reason or we get some news, then, we feel like we want to kind of keep moving forward. I think a little in another slide or two, we'll talk a little bit more about the options. Maybe that's on the next slide. So I don't know, Rose, if you want to get there at the same time, but, at this point, we're just going to say keep the short-term plans in existence. But if that program does go into effect on September 3rd, like it's supposed to, we're recommending that you discontinue all of the short-term disability plans. I think there's 40 different plan options in place today with various OEB entities, and instead just offer a couple of voluntary short-term disability options that folks could purchase. Again, the Oregon PFML, based on the information that we have today, which is still under development, but I mean, they're going to provide 12 weeks of payments, and the benefits are pretty much providing the same level of benefits that the OEB plans are in terms of the weekly benefit. The only time, where the Oregon PFML would provide 12 weeks of payments. And so if a member, is out with a baby and then later has, a car accident, so they have two different, 12-week periods, the Oregon PFML isn't going to cover all of that. So that's why we're saying, but it's more generous in many ways than the current OEB plan. So we would say, go with the Oregon PFML, offer a couple of voluntary plans for those folks who may want some additional coverage just in case, and the premium is going to be pretty low for those voluntary options.
And I'll note that the payroll tax funding actually starts January of 2023. So we'll have a pretty good run up before we have to make that decision. JJ.
I was just going to say the exact same thing you just said.
Sorry about that. I should have gone with your raised hand first.
Does that answer the questions? Okay. Okay, so let me see. I don't know if we have another slide for that. Oh, I think we have one more slide that just gives you a sense of what the annual premium is by line of coverage, but I don't, that's more reference, I would say. I don't know that we necessarily need to go over it. At this point, be helpful to get some feedback, but it sounds like I didn't hear a lot of opposition to some of the rate decrease proposals, other than maybe we want to continue to take a look at the optional life options on the table at the next meeting.
Okay, any final questions or comments? Well, I don't usually get to say this, but we are ahead of time. So let's go ahead and take our 10-minute break here, and we'll come back, let's say at 3:18, okay? So see you back at 3:18. Okay, board, if you could turn on your video so I can know when people are ready to go, that'd be great. Okay. Okay, Jenny, whenever you want to proceed, we are at the third of the three presentations from Willis Towers Watson, the OEB wellness programs for 22-23.
Jenny, you're on mute.
My turn this time. Okay, thanks. I'll walk you through the renewals for OEB's wellness vendor partners. I do have a couple of colleagues with me to help provide some of this discussion. The first is Matt Sendersky, and Matt has been working on the OEB team and the wellness programs for about a year now, especially with the WebMD implementation, but is pretty familiar with OEB's wellness programs. And then I also have Mary Kay Lopez, who is on the OEB team and is a clinical care management expert. She's a nurse by background, but has spent, I'll just say, Mary Kay, more than 20 years with Willis Towers Watson in care management and health management and population management programs. And so she's a really great, she's got really good insight into what makes a good care management program and how do you measure success. So let's go ahead and go to the next slide. We'll give you the executive summary. Just keep going. Go one more. Here we go. The executive summary. Matt will walk you through the renewals for what we call the traditional OEB wellness vendor program renewals, but essentially WW, which is also known as Weight Watchers, will recommend continuing the current programs. We have some recommended reporting improvements to suggest. On the WebMD 1 portal, which is brand new, Matt will talk quite a bit about that. At the end of the day, we are recommending continuing that program. For Canary, Canary has elected to discontinue their virtual lifestyle management or their pre-diabetes program. So we'll be talking about Moda's proposed pre-diabetes program as a potential alternative quite a bit today. Canary also offers another program called Better Choices, Better Health. At the end of the day, we are recommending that the board consider discontinuing that program and just focusing on the carrier programs, but we'll talk a little bit more about that. As I mentioned, Matt and Mary Kay will talk a little bit more about the diabetes prevention management program. What makes a good diabetes management program? How does the Moda solution fit into our sort of recommended framework or continuum of support for members with diabetes? And then at the end of the presentation, we'll talk about the Employee Assistance Program, or the EAP. We think that the EAP belongs in the family of well-being and wellness program support, so that's why we have it here. We have a renewal from Uprise Health, some updates on experience, and then an interesting new pilot to talk about that we're interested in rolling out. So I think from here, I will turn it over to Matt to walk us through the individual renewal programs.
Thank you, Jenny, and good afternoon to the OEB board. As Jenny mentioned, my name is Matt Sendersky. I'm a health management consultant here with WTW. I've had an opportunity to work on the OEB wellness program since about April of 2021, so bringing some insight to the group today just about additional vendor decisions that you have here coming up regarding your renewals. And the first one that we are going to dig into here is your renewal regarding WW. Or you may know it as Weight Watchers, but they have effectively changed their branding to WW. And just taking a look at the services that they currently provide the OEB members, you can see that the OEB program currently consists of their digital program, their digital and workshop, their Curbo, which is for the kids and the teens, and their digital 360. And if you look to the right here, this gives you a little bit more on this graph, a little bit more detail about what each individual solution offers to your members. OEB started with the digital base package, and then here recently has added the digital 360, the workshops, and the Curbo and the other components to the program. Now, some takeaways from this WW program are of note. Your most recent engagement numbers that were provided to the board at the end of 2021, or maybe it was really 2022, was that 8% of your current active members, or about 8,000 individuals, are currently engaged. And then what we did is we took a look at, okay, based on what the current engagement of those active members are, what are they primarily participating in? And you can see a majority of your members are either participating in the digital or the workshop, and then you have a small amount that are participating in the digital 360. And only 40 individuals are participating in the Curbo. So that would be your coaching for teens and kids. So you had a very small number of individuals that participated in that. Then taking a look at your outcomes, because WW is able to provide you with outcomes regarding your members and how they're participating and if they're driving any type of behavior change. So 27% of average active members lost 3% or more of their weight. And then what you really like to see in a weight loss program like this is that you have, your obesity scale, right? Your BMI scale, and it's going to range from healthy weight all the way to severely obese. And what you want to see over a period of time is you want to see individuals start to trend back down to that healthy BMI. And so you had 10% increase in healthy BMI and 7% decrease of members in the obese 3 category. And then the annual program cost, which you have there, is right about $1.425 million. Now, some takeaways for the WW program. As Jenny mentioned, we recommend that you continue with the WW program. Out of all of your well-being programs that you currently have offered today, this is your one with your highest engagement at 8,000 members. And I know that we've talked about this in the past. We believe a lot of that has to do with the brand recognition, right? People are excited about Weight Watchers. A lot of people participate in Weight Watchers. It's got a good B2C model, so a lot of people are familiar with it. So you had high engagement. But here's the caveat with your engagement numbers that I would go back and I would challenge WW. In fact, I've already challenged WW on this, is that they consider an active member of your population anybody who picks up their app or engages with their program. It's like 30 or 60 days. And I think it's 30 days, but they spread it out. So let me just give you a little example of why that's problematic. If I'm an OEB member and today is February 1st, and I pick up the Weight Watchers app and I look at a recipe, it's going to consider me engaged and active for the entire month of February, regardless if I never come back to the app again. And then if I don't touch that app again until March 31st, it's going to consider me active for February and March. And so I don't know really how much engagement or outcomes you're going to get out of it. So really sort of challenging that. And then also one of the things that came to our attention as we were reviewing this program was their lack of reporting capabilities regarding their coaching. So they do have coaching. It is available. They can't provide you any outcomes on their coaching or any movements on the stages of change. I was a health coach for many years, and one of the big things that we had in program components were you engaging with these participants? And if you met somebody and they were in contemplation, pre-contemplation, were you engaging them and moving them along the stages of change, setting goals, helping the individual achieve these goals, and then reporting those metrics back into your program? They don't have the ability to provide any follow-up reporting on that. So while we would keep with the WW program, those would be some recommendations that we would suggest the OEB board, the OEB team takes back to WW and discuss. So any questions on WW before we move to the next slide? No? All right. If we want to go to the, I sort of read, go right ahead.
Sorry, I have a question. I really appreciate your analysis of what would make this program better, especially around the coaching. So in your recommendation of somebody should go talk to them, Ali, is that you? Who takes that message to WW?
Yeah, we definitely would. We kind of work in partnership with Willis Towers with our wellness programs, and Teresa Cross has really been carrying the torch for PEP staff for a couple of years, and now is taking on OEB wellness as well. So it'd be kind of a team effort there.
Okay, Tom.
We discussed WW at CAL a month ago, or maybe it was 2 months ago. I'm not exactly sure now. And the recommendations that Matt is bringing forward are ones that we agree to. The one issue that we did not accept from WW was their diabetes program, because we thought at least there was concerns that it would conflict with some of the plan activities. So we are not including that. My understanding was WW was offering that for the first year free, but then there'd be costs that would come on at a later point. So all the recommendations, with the interest at finding out, probing more about the, what engagement means, and the
That's right.
and the recommendation around coaching and getting data from that, we're in agreement with.
Awesome. Thank you, Dr. Saltabo. Okay, so we're going to move on now, just in the interest of time. I know we got a lot to get through here before the top of the hour. So moving on down to the WebMD one, this is the next wellness vendor. OEB launched this back on November 1, 2021. There was a little bit of a delayed launch with this just due to some other priorities that were happening. Also, in fairness to everybody involved, this is when sort of the Omicron really scaled up. We had the holidays that really ramped up. So there was a lot of distraction when we launched the WebMD1 platform. But just to give the board a little rehash on what you currently have available through WebMD1, it's a online portal that individuals have the ability to go online and get daily recommendations, suggestions, information, habit tracking, pulse surveys on health information topics that are of interest to them. They also have some scheduled challenges that are going to be rolled out to the OEB population, educational resources, device and app integration. You get a dedicated program coordinator, Laura, who does a great job. 12 webinars, 12 newsletters, 52 virtual wellness breaks. They're currently working with Teresa and Jackie on developing a wellness champion network. And I think one of the things that Teresa, Jackie, myself, we did a really good job of is, if you see the screenshot here on the right, you can see the different cards that are available that populate the WebMD1 platform for OEB members. And one of the things we really worked hard on doing is integrating all the different benefit resources that have well-being areas of focus onto this platform. And that's one of the advantages of having a WebMD1 platform, is we were able to connect all the Moda resources, all the Kaiser resources, your EAP resources. So this is sort of like a one-stop shop for all of your OEB members to find anything wellness related that's available to them. Currently, there are 52 members registered on the site out of 99,800 eligible. So obviously, that's a number that we want to see significant increase in, right? And so we have some ideas, some things that you can do to help see an increase in this here on the next slide. The annual program cost is around $300,000. So it's only about 25 cents per eligible per month. So it's not anything too over the top. I mean, this is sort of, you don't have coaching available through this. You don't have some of the other bells and whistles that a WebMD1 program would have to it. So it's sort of the scaled down package. But recommendations that we would make is review best practice strategies to improve engagement, which we're going to talk about here momentarily, and then continue WebMD for the next 2022-2023 plan year. But I would have my eye on this WebMD program, and then reassess engagement after 1 year. And if you don't see these numbers increase, I would either discuss with them a per participant model or have other discussions on if there's better use of these resources. Because at 52 individuals engaged for what you're paying, there may be other opportunities there.
That's $5,800 per person registered.
Sure.
And
That's
they
very
need,
true.
yeah, and WebMD1 or WebMD needs to know that we will be looking at it, and the numbers have to significantly increase for us to maintain. I mean, I know why they want to do the per eligible member per month. I know why they want to do that. I personally think with the numbers that they have, they should have dropped it down by about 80% to more like a nickel per eligible member. Now that might not cover their costs, so I'm not exactly sure, but the numbers are, they need to know that they're under a microscope.
Yeah, I totally agree, Dr. Sotelo. The only thing I guess I would also just add is that, this is an online portal, and in order for folks to use it, they need to understand that it's available to them. And, so there needs to be multiple communications about the site, not only through OEB, but also really from entity wellness champions saying, hey guys, this is an awesome resource. Here's how you should use it. And ultimately, a program like this. So this is a really nice program, right, to offer. I think it's a value add for OEB to offer a program or a platform like this, but it only works if people are using it and find value. So that it should be used in conjunction with an entity's worksite wellness efforts. I would say over the last year that, priorities have, it's been really hard to focus on, activity trackers or, even managing your weight. It's like, it's all about mental and emotional support right now. That said, I guess I would hate for OEB to just sort of scrap a nice platform when it really could be leveraged and used a little bit more. But that's just.
And I agree with everything that you said. I agree with Jenny. The only issue is, it's $5,800 per registered person right now, and they need to know that that's not acceptable in the intermediate term. And if they wanted, if they, I would have been happier with us saying it's 15 cents per eligible member. And if they hit 1,000 people registered, then we bump it up to 25 cents per eligible member or something. Because right now it's a very, I agree, it's an attractive program in a time where life is turned upside down and inside out. So I think we'll give them time, but they need to know we'll have this conversation again next year, and at this time, and there needs to be a significant the number of wellness newsletters and webinars and things like that's all one thing, but it's going to be the participation that's going to be critical.
Agree.
So, Jeff, do you have before we move on, go right ahead, Jeff.
I see that there's a value to this program, but our members don't seem to see it. And we've been reviewing this program for over 3 years, well before COVID. So, what we're paying and what we're getting is grossly out of proportion. And WebMD needs, in my opinion, needs to offer us a much better deal in order to continue. Because if we can't get more than 52 or 50 whatever people on this, it could be golden, but we're not getting any value for our dollar.
So let's and Jeff, I totally agree, and Dr. Sotelo, I think we all totally agree with, but just in the essence of time, because I want to get to this next slide here and have a conversation with because I want to identify and just have this conversation, just so we can sort of look at both ends of the spectrum. So if we can go to the next slide, please. Because I think we can have a creative discussion around solution and best practices to drive optimal engagement and well-being programs. So, as I said, I've been working with you guys since April of 2021. Also, to just give you a little background, I've spent probably before I came to WW consulting in the public school district arena in the state of California for about the past 8 years. So I am very in tune to what really works well in the school district space in terms of promoting and implementing successful well-being programs. And so these were just some ideas that as we saw, we took a look at some opportunities that we could tweak some things that would help you guys get some more engagement. And I think one of the first things that I would take a look at is a coordinated communication campaign that aligned all of your messaging between the carriers and OEB. And just to give you like a little example, when we launched the WebMD program, we had 3 different messages coming out from 3 different entities about 3 different things at the same time. So you had Moda promoting one thing, you had Kaiser promoting one thing, and then you had OEB trying to send information out to the members, and the message was just lost. And so getting that coordinated message and getting everybody together on the same page in terms of your coordinated communication calendar, I think is of uber importance. And then number 2 is that WebMD, this is what WebMD would say back to the board. We have no direct access to your members. We have no way, no emails, no direct access, no way to communicate. So we are solely dependent. WebMD is solely dependent, 1, on getting information out through the carriers. And then number 2, developing this well-being champion network of people at the different entities where they can promote their program. And so we would suggest continued development of well-being champion network. Now we understand that you guys have many different entities there. So start with like the top 20. You know, I did an analysis of your top 20 OEB entities. And if you could get solid connections, that wellness champions that were willing to promote the program at those top 20 OEB entities, that would be a good core group of the members itself. So right now we don't have either of those. And then another one is incentives for participation. You know, right now there is no incentive for your members to participate in the program. And I know the challenges for a public entity, we're school districts, we're different entities. I've had this conversation with school districts. I've helped them work through this process. You can get there. It's just getting the right people in the right room to find the right avenue to be able to do this. Because if you can throw a $50 gift card or a $100 gift card out there, what that does for your well-being program is it opens a lot of doors in terms of these principals and these admins at your entities, allowing you to have presentations regarding this. And we'll get to the question just here in a second. So cash for gift cards, medical premium reductions. You know, I had a wellness program at one of my school districts a couple of years ago that they said, hey, we can't do individual gifts, but this is what we're going to do is we're going to do this competition, and the school district that gets the most people registered for this, the wellness program is going to pay for their Christmas party. And all the teachers rallied around this challenge to participate in this. So getting creative and doing some things like that. Vendor integration. So a vendor summit, meeting with all the OEB vendor partners to get everybody on the same page, all put together. And then revisit a broader well-being program strategy, focusing on the 4 pillars of well-being: physical, emotional, social, and financial framework and calendar of events. So I'm going to stop right there. I see a hand up, and when we open it up for discussion, because I think there's opportunity for us to have a great discussion on this page.
Reed.
Thanks, Robert. And I guess I have a question maybe for Ali through the chair, maybe to you. And hopefully you can hear me. Okay, there we go. So we already have OEA Choice Trust here in Oregon that's investing millions of dollars every year into wellness programs. And so they have these wellness programs with identified wellness champions. And I think the point of multiple people saying slightly similar things is a really good point, right? People get confused about where's my main message coming from and which is the main service we should be using. So the question I have for us is how, and I know we have in the past been working with OEA Choice Trust, but how could we take this information and have we already made plans to talk with OEA Choice Trust to help us be able to get access to folks who are already doing this work, as opposed to us reinventing the wheel? And I know that for a fact some of their programs do offer incentives, so they would be able to do things because of the grant funds that they have that we can't. But if we are able to tie the programs together, we enhance what they're currently doing.
Yeah, that's an excellent question, and we most definitely have been engaged and working with OEA Choice Trust through this. OEA Choice Trust, that their grant program, and then they have actually a lot of really nice tools to help people build their worksite wellness program. And yeah, so we've talked with the folks there, and even had WebMD on the involved in those conversations as well, to make sure that the WebMD portal can actually work to support the grants that folks get, right? Because this is a way for people to track their activity, or you can have various different challenges if you want to do that, and so the entities can use this as a way to promote it, and then the grants can help sort of fund some of the incentives or some other things.
Yeah, and
But the grants, I don't think, cover every single OEB entity that's available on the program. So that's the only gap, I guess. But you're right.
Yeah, and we did look at that, and I actually went to the OEB, I think it was the wellness workshop this year, the OEA Trust, excuse me, where they announced all that grant money that was available, and that was one of the things that we really wanted to act on, was that there was a certain amount of money that was available. I think it's available to like April 15th this year, and that can be used. It's pretty, no strings attached. You can use it for what you want, and what we wanted to do is connect with the OEB entities and get them to apply at the school level for it. Right, and then they could start to use that, and then we could support them in their initiative. And I know we have several hands up, and
yep. Let's go with Ali first, and then Glenn, and then JJ.
Oh, thank you. Yeah, I just wanted to mention we actually had a really nice conversation with OEA Choice Trust last week. Teresa Cross and I, through email, and she's going to get connected with all the contacts around the state to work with OEA Choice Trust and really get them connected and really start that to build that relationship with Teresa, and so that will be a really big step, and that's all I wanted to say.
Okay, Glenn?
Yeah, I just wanted to add some things that to kind of what Matt had pointed out is in regards to WebMD and communications. One thing to keep in mind is that the process that OEB uses right now is we communicate all the programs kind of at the same time. We're trying to keep these in coordinated communications about wellness overall with the different programs underneath. So they have been working very closely with Jackie and with others at OEB. There's going to be more communications going out. We've also promoted that all our wellness vendors do webinars, which WebMD is doing regular webinars, and it's going to be increasing actually their webinars on that. And they have been working very closely with their champion network. Also, they will be doing blast emails to the former Staywell registrants. They just had to get clarification on the privacy laws in regards to using those emails. So I would say, they've been doing a lot and are going to be gearing up and doing much more in regards to communications. But, it's not a case, as Matt pointed out, we had to kind of pull back on giving our wellness vendors direct access to all our employees. One for, some legal contracting, but also just because we didn't want so many messages coming to folks from different vendors. We wanted a more integrated, really themed message that would go across so it would appeal to more people.
Okay, JJ.
Just a couple things. Another challenge with giving folks access to employees is it substantially increases our cyber risk. There's a number of attempts to spoof employees by mirroring vendor logos and stuff. And we've had a few cases of that in the last couple of years. So that's just to protect our own folks. It's one of the reasons we've limited it. Also, just as the representative of local government, local government doesn't qualify for the school district grants and things. So the challenge, there's some extra challenges there. And then just as a perspective from an employee, I would say I'm a big dumb idiot, but I'm not very big. When I get communications from WebMD, a lot of folks don't realize this is a valid thing. They just think it's some, social media thing, or it's a way to remind me that I might have cancer. So marketing is a little challenging for this program. I think that's one of the reasons why we have such low enrollment.
Thanks, JJ. Erica.
Yeah, JJ, I just wanted to just point out that the Moda OEB Wellness Advisor Program does have grants available for all OEB entities. I think they've worked with Josephine County before as well. So even the entities outside of the school districts can apply for some grant funds up to $10,000 per entity through that program. And I put a link in the comments in case you're interested.
Awesome.
Great, thanks. Okay, Matt, I don't see any other hands, so you can
Yeah,
continue
let's
now. Thanks.
we'll go right on to the next slide. And I know an incident, we have a hard stop at 4, correct?
I need to check the agenda, continue, and I'll get back to you.
All right, I'll power through these next slides. So OEB Wellness Vendor Partners, Canary Health, Diabetes Prevention, and Better Choices, Better Health. So as Jenny alluded to, Diabetes Prevention Program, Canary Health discontinued that back in Q4 2021, so that one is off the table. They are still offering their chronic condition management, Better Choices, Better Health, but I just want to, and I know that we've had this conversation with the CL, but I just want to have this conversation with the board, make sure that we're clear that the Better Choices, Better Health program is not really technically a chronic condition management program. It's a peer-to-peer, like motivational interviewing program where I, as an attendee, will go to Better Choices, Better Health, and I'll sit down and they'll ask me questions like, Matt, what areas of your health are you interested in working on? What do you think that you need to do to overcome these challenges and barriers? How do you feel that you are being supported? So there's no really directional, okay, if I had diabetes, I could go in there and tell them I want to work on my finances, right? And so there's really no directional information that's given to the participants. So it's really that we have that clear, but you can see the participation that we had last year. And this just goes to tell you, like, and I don't want to say value because I think that's a little harsh, but out of 307 participants that started the program, you only had 46 that completed. So what that would lead me to believe, and I've participated as a facilitator and a participant in these classes, that after you go a couple times and you get asked the same questions, you just are like, am I really getting value from this anymore? And so that's why you see that number of people that drop. And so you see the annual cost in that 120,000, 195 per milestone. So we would recommend that you discontinue this relationship with Canary Health for that reason, that you have low enrollment, you get very limited reporting. I don't know how much value or outcomes that you're really getting out of this, and they couldn't report it to you anyhow. And so discontinue this relationship, and I would focus then more on the WebMD1, the WW, and then your Moda and Kaiser disease management programs that you have in place, and then review Moda's new diabetes prevention solution. I know we have some hands, so go right ahead. I'm sorry.
Okay, Tom.
Yeah, it's $2,600 for the BCBH peer support program for those who completed it. So I agree with Matt entirely that it makes sense to drop that. And his analysis of his recommendations, I am 100% behind. I wasn't interested in stopping the WebMD one this year, but we do need an improvement, and it would be for them in partnership. It would be, I think, helpful to see whether or not they're willing to lower their cost, because I think I agree. Jeff said he thought it was excessive. I agree it's excessive for right now, given what we're getting. If they said absolutely no, I would say, okay, we'll give it a year, but they're going to be viewed very critically in a year.
Okay, thanks. Glenn, do you have something else, or is the hand still raised from last time?
Sorry, I forgot to bring my hand down.
Okay.
All right, Matt. Go to the next slide. All right, I think we got a little delay here. All right, keep going. Gotta get this. Okay, so diabetes support. I think we're all aware. I presented back to the CI board in Q4 2021 just about the diabetes prevalence rate among the OEB population. So pre-diabetes and diabetes is prevalent health risk, not in the U.S. OEB population. 5,500 OEB members have diabetes, representing about 25 million in healthcare spend annually. So the purpose of today's discussion is review best practices in DPP or diabetes prevention programs, continuum of support for diabetic members. review Moda's proposed new pre-D program, review current solutions that are in place, and identify any new potential diabetes care solutions and strategies for OEB to review. So if we want to go to the next slide, please. All right, so best practice plan sponsor approach in diabetes management. And just for the team here today, we've already done a lot of this preliminary work that you're going to see in boxes 1 and 2. So we've conducted a current state evaluation. Jenny and her team in the analytics have done a great job looking at your medical and RX claims analysis. We've utilized a data warehouse to identify your diabetic population. You know, Moda Kaiser, they can also do some claims analysis there. Inventory and assessment of your current benefits, which we're going to jump to more materially to show you what the current state is. And then define potential performance gaps and opportunities for improvement. We've already done that a little bit too as well. You know, the reason why the Canary Health program, the DPP program that's being pulled was a big deal back in Q4 2021 was that was the DPP designated program that was offered to your Kaiser members. Now Kaiser does have DPP solutions available, but not a designated DPP program. I don't believe that's certified by the CDC. So that's a gap that we need to identify that we're going to address. So identify any performance gaps and opportunities for improvement. That's what we're doing some of that right now. And then I really think where we have the greatest opportunity here with the OEB population in terms of your diabetes care program is develop a strategic plan to improve engagement. So you have a lot of activities and resources that are currently available. Some of them are low utilized. So improve engagement, risk profiles, and outcomes. If we want to go to the next slide, please. Whoop. Feels there's like a little bit. Oh, there we go. Okay, so best practices for supporting members across the diabetes spectrum. So what you ideally optimally want to do is you want to engage with your individuals who are at risk for developing diabetes, people that go on high on the BMI chart, metabolic syndrome, and you want to engage with them and you want to provide interventions to start to reduce that risk and get them headed in the right direction. So you see your prediabetes, your metabolic syndrome, your weight management. On the far right, you see the OEB resources that are currently in place today. Moda and Kaiser, you have WW and WebMD, all have resources to help make a positive impact in this area. Then you have your diabetes management. So the person's pre-diabetic, they cross over the spectrum, they get into be diagnosed as type 1 or type 2 diabetic. And then how do we manage these individuals? So you can take a look at the programs that are currently in place. You have the Livongo, the Moda 360. Kaiser has a diabetes care management program. So you do have some resources available. Now, the one area, and then this is a new category that has currently been in the market here for a couple of years, is that there are programs out there that offer what's called diabetes reversal. And I think you guys may be aware of them, but there are certain programs, we're going to talk about one here momentarily, where they will engage with your individuals and through pretty aggressive nutrition, weight management programs, coaching, CGMs, the medication management, they will work on reversing your individuals who you have type 2 diabetes to the point where they are off their medications, they are at a healthy weight, they are no longer high risk on your claims. And we're going to talk about that here in a second. So if we can go to the next slide, please. And sorry, I'm going through this really quickly. I'm just trying to be sensitive to everybody's time here. Appreciate it. I know how faculty and staff get when it gets close to 4 o'clock. So, all right. So OEB diabetes care vendor and diabetes reversal options. So these are your plans that you have in place today, your diabetes care solutions that you have in place today. You can see Moda has this new DPP program, pre-D program, which we're going to talk about in a second. They also have their diabetes management programs that they have in place for type 1 and type 2, their Moda 360. Kaiser has prediabetes and diabetes management. You have your Livongo program, which is a Moda member specific program that has a diabetes prevention program and then a diabetes management program. And then you have WW, who also has suggested that they have a diabetes program. But I will just sort of caveat and put a little, Dr. Silderboat really hit the nail on the head when he said, hey, there was going to be some price increase. They weren't able to tell us what the price was going to be. So we decided not to move forward. But also in terms of best class program components for a DPP program or a diabetes care program, Weight Watchers had some boxes they still needed to check there. So, but they do have that solution that's available. And then the program that we were alluding to with the diabetes reversal would be Virta. I don't know if you're familiar with Virta, but they do pretty, aggressive keto diet, cellular glucose monitoring, coaching, medication management, where they actually work with your individuals to reduce them from the risk of having diabetes to off that spectrum. They put some pretty significant performance, 100% of their fees at risk around that. So that's just an idea suggestion to put out there. All right, let's go to the next slide, please. Okay, so the DPP scorecard, and what we did is we took Moda's pre-D program and we took Livongo's DPP program. And just a friendly reminder, you have Livongo in place through Moda today, through your Moda members, but I don't believe it has the DPP aspect. It's just your Moda, your Livongo diabetes care program that's available for them. And what we did is we just took best-in-class program components and then your required curriculum for the CDC. And I just want to point out that the boxes that we didn't check for Moda's pre-D program, we didn't check them because we felt that they were negative. We just didn't see any reference to these in the materials that Moda sent over for their program. So it wasn't negative, we just didn't see anything that it was listed there. So registered with the CDC as a DPP program, Moda has yet to have that done. You can see the Livongo program has that. You can see some of the program components that the Moda pre-D program does have in place. We didn't see anything mentioned there about moderate changes in diet physical activity that leads to 5 to 7% weight loss in the first 6 months. That's actually a real critical component of a DPP program as it relates to the CDC. Strategies, they have that. Weighs participants at each session. We didn't see any mention of that. That's another really critical component of the CDC curriculum. And then 22 of 26. So CDC has these modules that people need to complete as they go through their DPP program. We didn't see any reference to each individual models. There's 26. They need to complete 22 of those throughout their time in the program. So it would be another area that we want to take a look at. If we can go to the next slide, please.
Matt, I can give you 5 more minutes.
All right, I'm going to get through, and then these are just some additional ones. And you guys are going to get the copy of this presentation that you can review. What I want to do, since we have like 5 more minutes, is Jenny, do you want to go ahead and we can skip ahead towards the EAP slides?
No, Matt, we can talk about the EAP renewal at the next meeting. I think I'll just kind of wrap this up with a couple comments, and that is, because the Canary pre-diabetes program is being discontinued, and because Moda is proposing their own pre-diabetes program, we wanted to kind of have this conversation. We can certainly bring it back to the next board meeting where we have a little bit more time to kind of dig into this and talk about, the Moda program. We've just gotten some information from Moda. We got a little bit more information literally like last Wednesday or Thursday. So it's emerging, and I think it warrants a bit more discussion. And then, we also want to talk a little bit about Kaiser's approach and what they do. So it'll take more than 5 minutes. So I think this is a good start to the discussion. And I guess, Robert, if it's okay, we can just come back next month and continue this and the EAP.
That would be most, I definitely would like that, yes. Okay.
Awesome. Well, thank you guys, and let me know if there's any follow-up questions.
Okay.
Appreciate it. Have a great day.
Thanks to everybody at Willis Towers Watson. Really good. We put a heavy burden on you today, and you did very well. Thanks. Okay, Glenn, we're up for a legislative update.
Well, I'll try and keep this within the 10 minutes. Rose, can you go to handout 8? Thank you. Just wanted to give you a kind of a brief overview of the legislative session. As you know, we're going into the short session. It started today. And it will run till March 8th. Most of the work is going to be done in the first couple weeks. They have till the 14th to get the bills out of policy committees. They were just referred to committees. So they have until the 14th to hold a public hearing and then hold a work session and vote it out. Unless the bill is in Ways and Means, Revenue, or rules, and then they can be held to the end of the session. Then they move on to the second chamber, and they also have their own deadline that they need to meet. This year, because it is a short session, we do have fewer bills. Members have been allowed to introduce 2 bills, and the committees can put in 3. Overall, before I get into the top bills that we're monitoring right now, I wanted to say that, you know, they have a number of, they released their agendas today for, in regards to the Democratic Party in the legislature, and they really have identified the health workforce as one of the big healthcare areas they want to focus on. In regards to priority 1 or 2 bills, priority 1 bills would be bills that change OEB's programs, operations, policies extensively. There really are no bills that are priority 1 this year for this session. Priority 2 would be bills that have a indirect impact on OEB, usually through increased premium rates. This is usually focused on benefit bills. And we have 2 bills that we're watching this year, and we've already done analysis on. One of those is Senate Bill 1530, which is a bill that's is set down within the commercial market requirements for coverage of infertility services. And this is basically all infertility services that are recommended by a physician and in line with certain professional guidelines. And this can run from diagnosis all the way up to what's called advanced reproductive technology, which would be your IVF, as well as some other procedures. It also adds in a requirement for what's called crypto storage, which is crypto storage of both for men and women. This bill also, the other thing about this bill is it removes the capability to have benefit maximums on these type of services, and it reduces your cost sharing on these services to be equal to what other pregnancy related services are. Just a little bit of background. Right now, as you know, OEB does have infertility services, except it doesn't have IVF. And then it also has a $15,000 benefit maximum on medical services and $10,000 benefit maximum on pharmacy services. They have 50% cost sharing on the medical, and then varying cost sharing on the pharmacy. So basically what would happen for OEB is we'd have to cover services we're not covering right now, and we would have to remove our benefit maximum and then also lower our cost sharing for the medical services. We've run this through the consultants, and they estimate that it would be a 1.3% increase in our current medical RX premiums. The second bill is one that we've seen for the last 2 to 3 years. This is a bill to really equalize reimbursements for naturopathic physicians so that they would get paid the same amount as a PCP would for the same services. It has a slight reimbursement impact on us of 0.1% for our rates. Those are really the 2 bills that we're kind of following right now, at least that we've done analysis on. We're also following bills that, I'm sorry, Tom, did you have a question?
Well, I'm sorry. I was just getting in line. You finish your comments, and then I'll have my comment. I want to talk specifically about the infertility and the potential rate increases.
Okay. So it would have a slight impact. We are also following bills that we classify as what? Priority 3, priority 4. Priority 3 would be bills where It may affect us, say, through the benefit system, but it doesn't have any premium impact. Or it can just be accomplished if it is something, an added task for OEB within our current budgetary or staff resources. Priority 4 would be bills that are ones that we're just following because their relating clause is very broad. And let me explain. In Oregon, when a bill comes to be introduced and it has a relating clause for healthcare, it means that the legislature can literally strip all the content out of the original bill. I mean, it may say it originally applied toward health licensing. They could strip that out and add any other topic or content they want later, as long as it relates to healthcare. So we need to watch these bills to see if amendments come along that would add items that would impact OEB on that. So really, those are the bills we're following. I think we have about 20 that we're following in total. It's not as much as we've seen in the past, but we do have these 2 big bills that we're kind of working on right now. So,
Tom.
Yeah.
Oh,
So
sorry, Glenn.
yeah. So the issue is around the, if indeed it's a 1.3% increase to do all this cover, and we can obviously, check with our carriers, but it sounds like our consultants maybe have already done that. We should be proposing an amendment to this bill that would raise the maximum from 3.4 to 1.6% or 1.7%. The idea of adding things means that without being able to increase the maximum rates means that we have to cut other things. So every single time there is a requirement that's put on us, it may be the right thing to do. I'm not criticizing, I'm not saying infertility isn't important, managing it, but the idea of having a legislatively fixed amount of increase per year and then adding things, we should be whoever, and I don't know if we can do it or if we do it, how we do it, because I don't know anything about the process, but we should be every single time pointing out the conundrum that that OEB and PEB are under, and because the options are 2. We increase the amount, or when we add these additional services, we cut back something else. There isn't any other way to do it.
We do on every bill analysis which is our internal, but also the fiscal impact statements that go to the Legislative Fiscal Office and then to the legislators. We indicate that anytime there's a premium impact, no matter how slight, 0.1 or 1%, we indicate this further challenge, that it further challenges our capability to meet the legislative required 3.4%. And we stress that in all our communications, but we've been doing that, I think, about 3 years.
Robert, you're muted. Robert, you're muted.
I almost got all the way through too. Thank you, Glenn. We're going to move on to Ali.
Oh, thanks. And Tom, you're right. We actually have a little blurb that we put on every fiscal impact that says exactly that, that this stresses our ability to meet the 3.4%. And
but no one listens.
No, I know that's what and Glenn and I have this discussion all the time about benefit mandates, and they're always coming. The advocates are always coming after us. But
right. the other, it's more than it stresses us. It's the conversation for us is, what do we stop? If we have to add, what do we stop? Now that might be the right conversation, but it can't be done. You know, in a zero-sum game, you add and then you have to subtract. And the communication saying that it stresses us, no, it doesn't stress us. It means we have, in a zero-sum game, we have to do something different. We have to move more costs to our membership. We have to dumb down coverage. That's the only way that you get there. So I guess I would be more aggressive in terms of the communication is what I'm suggesting.
Well, we put they get more afraid of the number, but you're right. I mean, we don't just put stresses us. We actually put the numbers forward and request that they increase our budget, which is usually what, you know, causes the big pushback. But yeah, we can strengthen that language for sure.
JJ.
A couple things. Can we get our best guess number? And the reason I ask is OEB as a whole, OEBB is not allowed to do certain things. However, we have members on the board that are affiliated with fairly influential collective bargaining groups. And a lot of these legislators listen to those collective bargaining lobbyists. So ultimately, if we go to the legislator who's trying to do good things for the citizens and we tell them this good thing will be offset by another bad thing, they'll listen to that. The other thing I'd like to see, if it's possible, is when we know that there's a substantive impact that's going to make us have to make cuts to plans, can we work to have someone from OEB, whether it's someone on the board or management within OEB, try to get an appointment with some of the legislatures just to have a face-to-face. This is the actual impact this is going to have.
Yeah, that's a great comment, and we do have meetings periodically with members of the House and Senate healthcare committees. I personally do about every quarter, and especially on a couple of the bills that Glenn mentioned. These are ones that have come up, you know, in years past. So there's pretty direct line of communication. And one thing I would also say is we have the OEB stakeholder group with representation of our stakeholders that we're meeting with in a couple of weeks, and we'll definitely give them the rundown on legislation impacting OEB, and they're more than happy to communicate through their various channels how this would impact the program. So not just coming from staff, but from our stakeholders as well. So I just wanted to quickly mention, I mentioned at the last board meeting a directive from the Health Authority Director that all work groups and committees that involve providers, including health systems and insurance carriers, be put on a temporary pause to free up their time to focus on the Omicron variant. All staff are also put on notice to possibly jump into that fray and to other roles supporting that effort. And the IWG and CL were put on hold for February and March. I'm hopeful that with the declining number of cases, we could get back to work in March. But for now, we are to continue on that hold until the pause is lifted. And I just wanted to update the board on that. And that was it.
Thank you, Ali. Rose, do we have any public comments?
No, not that I know of.
Well,
phone,
I'm sorry, go ahead.
unless somebody's on the phone wants to speak up, but no, I don't have any.
Okay. Well, I think that brings us to the end of another OEB board meeting. I look forward to seeing you back in March, and the work continues. Goodbye, everybody, and this meeting is adjourned.
Thanks so much.